A very good evening and warm welcome to one and all. I welcome all the delegates, the faculties, all the dignitaries who are present today with us. And accepting the new normal, we have created an e-platform to welcome all of you to join with us in the 5th National Conference, which is a 2-day conference by Howrah Town Diabetes Study Society. Well, here what we see that HTDSS is basically a team of doctors who are from various fields. They had a motto of inculcating together and come with an aspect of providing a platform of sharing knowledge to the mass and for the betterment of the society. Before moving forward, I would like to introduce HTDSS. Well, HTDSS was founded on 1st of
Hello.
July 2018 by few like-minded, enthusiastic and dedicated doctors who have an interest in the field of diabetes and its related complications and its specialties. And I am honored and
Hello.
blessed to invite all of them today who are the founders and members and pillars of HTDSS. Well,
Shrimati, you'll have to unmute yourself.
So with great honor and with due respect, I would like to invite all the founder members and pillars of Howrah Town Diabetes Study Society. They are none other than diabetologist and endocrinologist, Dr. Sanjay Kesha, cardiologist, Dr. B.P. Pandey, consultant physicians, Dr. Mridul Bera, Dr. Guru Prasad Bhattacharya, Dr. M.L. Bansali, Dr. Shoykot Ghosh. We also have nephrologist, Dr. Bismay Kumar, gastroenterologist, Dr. Dilip Todi, neurologist, Dr. S.K. Somani. Well, HTDSS launched of HTDSS to raise awareness about diabetes, conduct social and scientific programs, and the simplistic aim of this organization is to expand beyond Howrah and spread its wings towards the mass and towards the society. They have created a platform to invite all dynamic and young doctors to participate in the continued medical education and enhance learning, interacting, and applying updated knowledge for the betterment of the society. Well, with this, I would like to say that HTDSS, Howrah Town Diabetes Study Society, welcomes you to a veritable feast of practical diabetology and related medicine from the frontline warriors in the difficult times. As we all know, going by the COVID situation, going by the pandemic situation, as we all know that adapting to being informed, to be prepared, to be smart, and to be safe is something that we should do and follow. And they pledge to be Atmanirbhar by learning and sharing together on this unique e-platform for the doctors and by the doctors. So hereby, I welcome you all to this scientific feast, which is called Surviving with Diabetes in the COVID era. Before starting our program, I would also like to thank our dignitaries who are the patrons, the supporters who have been with us, who have been with HTDSS and enriched them. I, on behalf of HDS, give a special thank you to the senior teachers who have enriched the core strength of the organization and made each endeavor successful. They are none other than our patrons, Professor Dr. Shamur Banerjee, Professor Dr. Shivananda Datta, Professor Dr. Dasharati Sarkar, Professor Dr. Arun Majumdar, Dr. Buddhadev Mukherjee, and Dr. T.K. Pal. I also thank you, the executive committee members, Dr. Ashok Mukherjee, Dr. Shukumar Barik, Dr. Shotish Gupta, Dr. Shayok Roy, Dr. Shottam Chakraborty, Dr. Somnath Noshkar, Dr. Kaushik Pahari, whose wholehearted involvement made this event a memorable one. Well, as you all could see in the video, that HDS has done innumerable conferences and programs which have created awareness and a scientific feast all over in the field of medicine. Well, they came into action with subsequent conference and spread its wings, conducting educational awareness programs for nurses and people with diabetes. They observed a walkathon, as also they participated with Howrah City Police in educating the police personnel last year on the day of World Diabetes Day. And thus inculcating various personalities together made this whole endeavor successful and possible. Well, I also now move on to thanking, last but not the least, who are also two important pillars of HDS, none other than Jayati Bhattacharya and Palgunisha. Along with that, I also thank all our industry partners without whose help the programs would not have been successful. So, coming to the end of my talk, I would like to move on to the very important part of today's program, that is observing the national anthem. Well, today on this eve of Independence Day, I thank one and all who have come forward and joined with us on this evening. And as we know that having freedom in mind, having faith in our words and pride in our souls, we should salute our nation on this Independence Day, and let's observe the national anthem now. Thank you.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा
Welcome back, one and all. This evening, I welcome you all to this scientific feast. And with positivity in our heart and in our mind, we would like to move forward. And before moving forward, I would like to invite, I am blessed and honored to invite Dr. Sanjay Kumar Shah, who is none other than the founder president of HTS. And he basically needs no introduction. He's a senior most endocrinologist of Howrah, who is the HOD Department of Endocrinology of Narayana Super Speciality Hospital. And sir, we are waiting to hear you.
Thank you, Shimanti, for that kind introduction. Good evening. Thank you all for joining this virtual conference at Howrah Diabetes Society. It is an honor to be in front of you all on this happy 74th Independence Day. We today are going through challenging times, the COVID-19 pandemic, which has forced us to innovate and stay connected digitally. Standing before you makes me nostalgic and reminds me of our very first conference on Doctors' Day, July 2018. We, the doctors of Howrah, had been participating, attending many local, regional, national, and international conferences, came together thinking about creating our own Howrah Diabetes Society. Taking a cue from our Prime Minister's Independence Day speech, it was about becoming vocal for local and making Howrah Atmanirbhar in the field of continuing medical education in diabetes. We like-minded, enthusiastic, dedicated doctors having an interest in the field of diabetes and its related specialties, formed this unique society. The aim of this group is to raise awareness about diabetes, conduct social and scientific programs, as you've seen in the video, to enhance learning, sharing, interacting, and applying updated knowledge for the betterment of the society at large. In short, bringing science to practice. We, the founder members, the cardiologist, Dr. Pandey, Dr. Somani, neurologist, Dr. Todi, gastroenterologist, and Dr. Bismay Kumar, nephrologist. As you can appreciate that these four specialties are linked and woven and bonded with diabetes as a common thread. We also are helped by our consultant physician colleagues, hardworking and providing uninterrupted service to the community in large numbers, particularly Dr. Mridul Bera, Dr. Guru Prasad Bhattacharya, Dr. M.L. Bhansali, and Dr. Shoikot Ghosh. We nine formed the Howrah Diabetes Society. After our success of the first conference, Diabetes 360, we continue to have CME twice annually with topics like diabetes and the family, diabetes and complications, and early this year, more in diabetes. With each passing conference, there was a learning phase to enrich our core strengths. Doctors with an interest in diabetes joined us to make our organizations bigger and better. A special thank you to our senior teachers who, with their unstinting support, joined us in our endeavor as patrons. And you've heard about them from Shimonti, Professor Somar Banerjee, Professor Shivananda Dotto, Professor Dashruti Sarkar, Professor Arun Mojumdar, Dr. Buddhadev Mukherjee, and Dr. T.K. Pal. As we gathered pace with our activities, our colleagues chipped in with their wholehearted involvement as executive committee members. And with each making of an event, they made it all a memorable one. Dr. Gupta, Dr. Barik, Dr. Mukherjee, Dr. Shayak Roy, Satyam Chakravarti, Somnath Noskar, and Kaushik Pahari. Our aim is to promote and empower our young doctors and the not so young as well, as one lifetime is too short to accomplish our dreams and aspirations. I, for one, holding this virtual conference, have learned to engage in the digital mode, and I am sure it is the same for a lot of my colleagues in this journey. Lifestyle modification is an integral part of diabetes care, and we are grateful to our dietitians, diabetes educators, and nurses to be a part of this journey. We conducted educational programs for nurses, people with diabetes, and diabetes awareness campaigns like the Walkathon on World Diabetes Day. The who's who of the society participated in our activities, making it one of our unique features of involving more and more people from the community, so much so that it became a social event in the calendar of Howrah municipality. All this has been made possible by the support of our industry partners. A very special thank you for their contribution. A very special thank you also to the women who the administration at Howrah Diabetes Society, a particular special Jyoti Bhattacharya, who is ably supported by Falguni Shah, Shimonti Chandra, and Rakhi Chatterjee. whose presence during and after the event must be acknowledged for making each event a grand success. Our aim is to expand beyond the horizons of Howrah and set new goals for ourselves, thus realizing our true potential in the field of continuing medical education in diabetes and related specialties. We, for one, are truly excited to bring to all surviving with diabetes in the COVID era on this special Independence Day weekend as a digital conference. God bless, stay safe, stay healthy. Jai Hind, and thank you. With this, we move on to the lamp lighting ceremony. Thank you.
What to Srimanti?
Sir, before we start the program, can we display the Zoom rules for our delegates? I would like to request all our participants, our delegates and faculties, and everyone who has joined with us today evening to go through the Zoom rules and follow it throughout the sessions. I would like to highlight a particular point for all our participants, since we have an array of scientific sessions and you might be having a lot of questions with you, but we would be taking 2 questions for each session because we will run short of time as we are on an e-platform. So you have a participant option on the screen. You click on that, and beside your name, you have an option which is called raise hand. So if you click that and raise hand, we will unmute you and take up your question. Otherwise, you can also write to us on the chat box. Well, with this, I would like to request for displaying the scientific sessions that we have for today. Well, so it is a real pleasure to come together again on this 5th national conference, which is a 2-day virtual conference that we are observing on behalf of Howrah Town Diabetes Study Society. And I would like to brief on behalf of HTDSS that we have an array of scientific sessions, and absolutely today when we are going to end, you will be going back enriched and with a lot of positivity and lot of knowledge. Well, so as HTDSS has this practice of starting their sessions with musical therapy because they believe that music is the medicine, it is the natural medicine for the soul, mind, and the body. So we will be observing a musical session in the beginning, and with that, we will move forward to the scientific sessions. So for this, I welcome here Dr. Shukumar Barik, the moderator of the first session, that is staying positive in the COVID era. I would like to introduce Dr. Shukumar Barik, who is a consultant obstetrician and gynecologist attached to Narayana Multispeciality Hospital. He is an associate professor at Eye Care Institute of Medical Sciences, and he also has many national and international publications. I take pleasure and I am blessed to invite Dr. Shukumar Barik today for the first session. and let us get enriched musically and move forward to the scientific session.
নমস্কার, শুনতে পাওয়া যাচ্ছে? With all the permission from everybody, I think initially এই সেশনটা আমি একটু বাংলায় বলার পারমিশন নিয়ে নিচ্ছি। শুভ সন্ধ্যা। এ এক অদ্ভুত সময়, অভাবনীয় সময়। কোভিড অভিঘাতে চেনা পৃথিবী কেমন যেন অচেনা। বদলে গেছে অনেক কিছু, বদলেছে মন, বদলেছে সুখের সংজ্ঞা, বদলেছে কাজের ধরন, বদলেছে চাওয়া পাওয়ার হিসেব। সারা জীবনে আকাঙ্ক্ষিত ছিল নিজের মতো করে একটু সময় পাওয়া। এই দুঃসময় এই কাঙ্ক্ষিত সময়কে এনে দিয়েছে কাছে। ভালো লাগা জিনিসগুলো সময় পেয়ে ডানা মেলতে শুরু করেছে। ছবি আঁকা, প্রিয় বই পড়া, টুকটাক লেখা, সিনেমা দেখা, গান গাওয়া ইত্যাদি। এইসব নানান অকাজের সুখানুভূতিও কিন্তু কম পাওয়া নয়। গান গাওয়া আমার কর্ম নয় ভেবেই এবং বুঝেই গানের কথা লেখার একটা বিনম্র প্রয়াস এসেছিল মনে। তারপর সুরদর কথা আসে এবং তার জন্য চলেছে গুণীজনের খোঁজ। এই খোঁজাতেই আবিষ্কার করা হলো শ্রবণাকে। শ্রবণা রায়চৌধুরী আমার হলদিয়া মেডিকেল কলেজের এক ছাত্রীর বান্ধবী। রবীন্দ্র ভারতী থেকে মাস্টার্স, বিশেষ প্রতিভাবান শিল্পী, অবশ্যই খুবই ইয়াং, গানেই নিবেদিত মন প্রাণ। আমার সাথে আজও দেখা হয়নি মুখোমুখি, এই কনফারেন্সের মতোই এখন অনেক কিছুই ভার্চুয়াল। আজও কয়েকটি গান পরিবেশন করবে সে। শেষ গানটির কথা আমার লেখা, সুর ওর দেওয়া। চলুন ভালো থাকি এই কুড়িয়ে পাওয়া মানব জীবনে, চলুন ভেসে যাই কিছু সময় গানে গানে। নমস্কার। এখন শ্রবণাকে অনুরোধ করছি গান শোনানোর জন্য। শ্রবণা, যদি এসে থাকো, হ্যান্ড ওভার টু ইউ।
নমস্কার সকলকে। প্রথমেই আমি এরকম একটা সন্ধ্যায় উপস্থিত থাকতে পেরে প্রত্যেককে, এই দেশের প্রত্যেক সদস্যা এবং সমস্ত ডাক্তার গুণীজনেরা, তাদের প্রত্যেককে আমার আন্তরিক শ্রদ্ধা জানাই। আমি আজকে দুখানি গান শোনাবো। প্রথম গান রবীন্দ্রসঙ্গীত। আজকে তো স্বাধীনতা দিবস। স্বাধীনতা দিবসের জন্য এবং এই পরিস্থিতির জন্য আমার মনে হয়েছে প্রাসঙ্গিক, তাই সেই গানটি ভেবেছি। এবং পরের গান স্যার বললেনই, ডক্টর সুকুমার বারিকের লেখায় আমি একটু চেষ্টা করেছি আমার মতন করে একটু সুর দিতে গানটায়, এবং আমি গেয়ে স্যারের কথা অনুযায়ী আমার ইউটিউব চ্যানেলে সেটা প্রকাশ করেছিলাম। আমি এই দুটো গান আজকে একটু আপনাদের সকলের সামনে শোনানোর চেষ্টা করছি। নেটওয়ার্ক ইস্যু বা অন্য কোনো সমস্যা বা আমার গান কোনো অংশে ভুল হলে আমাকে ক্ষমা করে দেবেন। আমি আমার মতো করে চেষ্টা করছি। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। তবে একলা চলো, একলা চলো, একলা চলো, একলা চলো রে। তবে একলা চলো, একলা চলো, একলা চলো, একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি কেউ কথা না কয় ওরে ওরে ও ভাগা, কেউ কথা না কয় সবাই থাকে মন ফিরায়, সবাই করে ভয়, তবে পরাণ খুলে তুই মুখ ফুটে তোর মনের কথা একলা বলো রে, তবে মুখ ফুটে তোর মনের কথা একলা বলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি সবাই ফিরে যায় ওরে ওরে ও ভাগা, সবাই ফিরে যায়, যদি গহন পথে যাবার কালে কেউ ফিরে না যায়, যদি গহন পথে যাবার কালে কেউ ফিরে না যায়, তবে পথের কান্না তুই রক্তমাখা চরণ তলে একলা দোলো রে, তুই রক্তমাখা চরণ তলে একলা দোলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি আলো না ধরে ওরে ওরে ও ভাগা, আলো না ধরে, যদি ঝড় বাদলে আধার রাতে দুয়ার দেয় ঘরে, যদি ঝড় বাদলে আধার রাতে দুয়ার দেয় ঘরে, তবে বজ্র নলে আপন বুকের পাঁজর জ্বালিয়ে নিয়ে একলা চলো রে, আপন বুকের পাঁজর জ্বালিয়ে নিয়ে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। ধন্যবাদ সকলকে। এরপর এবং আজকের অনুষ্ঠানের আমার শেষ নিবেদন ডক্টর সুকুমার বারিকের কথায় আমার সামান্য প্রচেষ্টা সুর দেওয়ার এবং আমার কণ্ঠে। মেঘ চলেছে উড়ে উড়ে রাজের ঘোড়ায় চড়ে, ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি, এমন দিনে মেঘ চলেছে উড়ে উড়ে রাজের ঘোড়ায় চড়ে, ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি, এমন দিনে মন পাখিকে ধরতে গিয়ে পালাই কোথায় বারে বারে, মন পাখিকে ধরতে গিয়ে পালাই কোথায় বারে বারে, খুঁজি তারে যখন নদী কিনারে, এমন দিনে মেঘ চলেছে উড়ে উড়ে রাজের ঘোড়ায় চড়ে, ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি, এমন দিনে এমন দিনে ঘরে বসে বিভাগী মন উদাস হচ্ছে, তোমার কথাই মনে ভাসে সারাক্ষণই, এমন দিনে এমন দিনে ঘরে বসে বিভাগী মন উদাস হচ্ছে, তোমার কথাই মনে ভাসে সারাক্ষণই, এমন দিনে অঝোর ধারায় বৃষ্টি ঝরে, বিজলি হাসে কেমন করে, পাগল হয় নেচে নেচে, অঝোর ধারায় বৃষ্টি ঝরে, অঝোর ধারায় বৃষ্টি ঝরে। এমন দিনে আমার সাথে ভিজবে তুমি কি, এমন দিনে আমার সাথে ভিজবে তুমি কি ও বধুয়া আমার সাথে ভিজবে তুমি কি ও বধুয়া আমার সাথে ভিজবে তুমি কি মেঘ চলেছে উড়ে উড়ে পক্ষীরাজের ঘোড়ায় চড়ে ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি এমন দিনে ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি এমন দিনে ভেসে ভেসে কোথায় যাবে কেউ তা জানে কি এমন দিনে। থ্যাংক ইউ সো মাচ। আবারও আমি আমার অশেষ কৃতজ্ঞতা জানাই এবং সকলকে আমার আন্তরিক শ্রদ্ধা প্রণাম। আমি সকলের থেকে বয়সে যোগ্যতায় অনেক ছোট, সকলের কাছে আবার কৃতজ্ঞতা সশ্রদ্ধ প্রণাম জানাই। নমস্কার।
Thank you so much. With this enriched, rejuvenated, and as I said, music therapy is kind of a natural medicine for our soul, body, and mind. With this, we move on to the starting of the scientific sessions, and I request to display the next slide. And this particular session is brought to you and sponsored by our industry partner. And with this, I welcome the moderator for this particular session, Dr. M.L. Bhansali, who is a senior consultant physician with 38 years of experience in the field. And the topic for the next session is practical consideration of second generation based insulin in current situation and adult vaccination in diabetes. Over to you, Dr. Bhansali.
Good evening and welcome all to this 5th HTDSS Con. Today in this session we are having two topics. First topic is practical consideration in using second generation basal insulin, and our speaker is Somik Goswami. He is a renowned endocrinologist of the city. He is faculty and in charge of Research Laboratory Department of Endocrinology, NRS Medical College, Calcutta. He is also associate editor of Indian Journal of Endocrinology and Metabolism. He is joint secretary Diabetic Association of India West Bengal branch, and he is having 47 publications to his credit in national and international journals. And today's topic is second generation basal insulin. As we see that when OHF fails, we start using basal insulin, and after that as the disease progress, then basal plus or basal bolus. So I welcome Dr. Somik Goswami to share his experience and expertise that how to initiate.
So very good evening to everyone. I hope I'm audible.
Yes.
Okay.
Yes.
A very good evening to everyone once again, and I think we are in the midst of what I consider to be the new abnormal. Yes, you heard me correct, it's the new abnormal, because everything is abnormal now. Things have become more difficult, including the management of diabetes. And what I'll try
Hello,
to...
how to you, Dr. Goswami? Hello.
Hello.
Yes, join. Thank you, sir.
Okay, and what I'll try to do over the next 10-12 minutes is try to make this new abnormal a bit more normal by looking at the evidence that is there with regard to the use of a modern basal insulin. So we take a patient who is an elderly gentleman with diabetes for the last 20 years along with hypertension. He is on what we call basal supported oral therapy, 18 units of U100 glargine, 4 different oral anti-diabetic drugs, an antihypertensive and a statin. But the problem which has brought him to us in the first place is that he is experiencing occasional episodes of hypoglycemia. He has symptoms of hypoglycemia, and when he measures using a glucose meter, the capillary glucose is around 60 to 65 milligrams per deciliter. So he came to us for the first time in May. It was lockdown. He had a lot of difficulty coming to us, but he did reach our chamber. And at that time, we found that he was somewhat overweight. His blood glucose was not well controlled. The HbA1c was 7.6, fasting 134, postprandial 188. And at that point of time, based on his creatinine and his age, he already had developed mild renal dysfunction. So if we look at this middle-aged, rather elderly gentleman with diabetes, with not very good glycemic control and having mild renal dysfunction and experiencing occasional hypoglycemia at the same time, I think we need to answer two major questions. One, how can we reduce his risk of hypoglycemia further? Because he's very tensed. He says that if I develop something major, I have to land up in an emergency of a hospital. I'll be exposed to COVID-19. I might not get a bed. So in present times, hypoglycemia is something which we need to avoid at all costs. And the second question would be, what will be his target HbA1c? Are we happy with 7.6 or should we do better? Now, coming to the second question first, if we look at guidelines, most guidelines tell us that in the elderly, a HbA1c of less than 7.5% is good. But at the same time, like in this gentleman who has a reasonably good life expectancy, doesn't have very severe comorbidity, is functionally well, possibly a HbA1c of 7 would even be better. But we have actually made things more difficult. He is experiencing hypoglycemia and we want his HbA1c to be even lower. Now, are the both possible in his case in the same time? As I said, he is already on 4 different oral anti-diabetic drugs, optimal dose, so we cannot do anything there. The only thing with which we can adjust further is possibly his insulin. And as I said, he was on a U100 glargine at the time of first visit. We know that U100 glargine has been a big technological innovation over NPH. But then again, when we are talking of 2020 modern times, we have even more modern insulin. We have U300 glargine, and of course we have injection degludec as well, which are even more advanced basal insulin as of now. But the question is, does U300 glargine have an advantage over U100 glargine? In terms of pharmacology, there's a lot of data to show that U300 glargine has a more stable pharmacologic profile, can be given at any time of the day with similar sort of efficacy. But then again, as clinicians, we would possibly be more interested in data which has looked head-to-head between, say, U300 glargine and the older U100 glargine, and that is what we'll discuss over the next few slides. If you look at elderly individuals with type 2 diabetes, there was a trial called the Senior RCT, which exclusively included older individuals more than 65 years old, divided them into 2 groups and compared the effects of U100 glargine with the newer U300 glargine. And it found that in all these elderly individuals, it could be more than 65 or more than 75, use of U300 glargine was associated with lower overall hypoglycemia compared to U100 glargine. And it was not only overall hypoglycemia, but more importantly, nocturnal hypoglycemia, which was reduced significantly with the use of U300 glargine compared to U100 glargine. And we know that it is nocturnal hypoglycemia, which is something which we need to avoid, particularly in elderly individuals with diabetes. And of course, there are other studies as well, which have shown that we not only achieve lower hypoglycemia with U300 glargine compared to U100 glargine, but possibly even better glycemic control. Now you can ask me that how is one insulin more efficacious than another insulin? Because we know that the overall dictum is that most insulins are similar in terms of efficacy. Now the answer lies in the fact that if you have an insulin which causes lesser hypoglycemia, you get more confidence, the patient gets more confidence in up-titrating, and in turn, this greater up-titration with confidence results in lower HbA1c, better glycemic control. Of course, there are not only randomized controlled trials, but real world evidence as well. This being the real world evidence of U300 glargine showing that it is as good as any other basal insulin, with the added advantage of reducing hypoglycemia significantly in a real world setting in older individuals with type 2 diabetes. Now, in the elderly, I gave you studies which have shown that U300 glargine reduces the risk of hypoglycemia compared to U100 glargine and possibly helps us attain even lower HbA1c levels. Now, what about renal impairment? Elderly, good enough. What about renal impairment? Here we have data published from the so-called addition trials, 3 trial data pooled together, which shows that in patients with mild renal insufficiency, as our patient has, as well as in patients with moderate renal dysfunction, U300 glargine has much lower risk of hypoglycemia compared to U100 glargine. Another study, subgroup analysis, this included not only moderate renal dysfunction, but even severe renal dysfunction. So EGFR less than 30 as well. Even in this group with more severe degrees of renal dysfunction, U300 glargine carried a lower risk of hypoglycemia. So in the elderly, in those with renal dysfunction, we already have looked at data how U300 glargine has a distinct advantage over U100 glargine. But as we said earlier, there's another modern insulin which we have to consider as well, and that is injection degludec. So if you look at data comparing the efficacy of injection degludec versus injection U300 glargine as the primary endpoint, the only trial which has looked at efficacy head-to-head is the BRIDE study, which found that both these drugs had similar efficacy, but when you were up titrating, the risk of hypoglycemia was lower with U300 glargine compared to injection degludec. And of course, in a practical sense, price-wise, cost-wise, U300 glargine is somewhat more economically priced compared to injection degludec. Interestingly, in the same trial, when a subgroup analysis was done, those with moderate renal dysfunction had even better glycemic control with U300 glargine compared to injection degludec. So in some groups, it could actually give rise to better glycemic control. When we talk of glycemic control and when we talk of renal dysfunction, something which we need to keep in mind is the albumin level of the patient. We know that in chronic renal dysfunction, the albumin level might come down. In patients with diabetes who have chronic liver disease for a variety of reasons, the albumin comes down as well. And if your albumin is less than 3.8, and if you are on injection degludec, your risk of hypoglycemia might actually increase. This is because injection degludec is more than 99% bound to albumin. It has a very small percentage as free fraction which acts on its receptor. The moment the albumin comes down, the free fraction might increase, bind more to its receptor, leading to more hypoglycemia. So in certain situations, U300 glargine could be beneficial in terms of hypoglycemia as well. And talking of the BRIDE study, there was another subgroup, about 161 elderly patients, 70 years or older, in whom too U300 glargine showed better HbA1c reduction compared to injection degludec. So there are 2 BRIDE study sub-analysis, moderate renal dysfunction and the elderly, in both of which U300 glargine shows better HbA1c reduction compared to injection degludec. And of course, there are a couple of smaller studies as well. This is a study from Japan, which used 5 days continuous glucose monitoring, randomized crossover trial. 15 patients in either group first received U300 glargine and degludec, and then they were crossed over. And it was found that U300 glargine and degludec, in terms of 5 days continuous glucose monitoring, gave similar glycemic control, but the risk of hypoglycemia was lower with U300 glargine compared to injection degludec. This again is another study which used 14 days ambulatory glucose profile, longer time glucose monitoring, which again showed that the risk of nocturnal hypoglycemia specifically is much lower with U300 glargine compared to injection degludec. So we have looked at trials in the elderly where U300 was better than U100 glargine. We have looked at trials in renal dysfunction where again U300 glargine had lesser hypoglycemia compared to U100 glargine. And when we compare U300 glargine and degludec head to head, we find that efficacy wise, they are more or less similar. In certain situations, the U300 glargine might have even better efficacy. And of course, there are small studies suggesting lower risk of hypoglycemia with U300 glargine compared to injection degludec. So keeping all these evidences in mind, what we did in our patient was we switched the patient from U100 glargine to U300 glargine at the same dose, 18 units to 18 units, 1:1 dose conversion. We asked him to monitor his fasting capillary blood glucose every 3 to 4 days and on a weekly basis increase the dose of U300 glargine by 2 units depending on the fasting blood glucose to reach a fasting plasma glucose of around 100. And we asked him that if he experiences hypoglycemia, give us a telephone call. What happened was that over the next 3 months, when he came for the last follow-up just a couple of days back, his dose of glargine now was 22. So 18 units of U100 was shifted to 18 units of U300, gradually up-titrated. He was now on 22 units, but what was important was that his blood glucose had come down, and in spite of having lower HbA1c, there was no episode of hypoglycemia in the last 3 months compared to a higher HbA1c and occasional hypoglycemia when he first came to us about 3 months back. So if you have better glucose control and lesser hypoglycemia, automatically your quality of life, your satisfaction improves. And I think this is something which is very, very important in the present times, in times where we would not want our patients to come to our clinic frequently complaining of hypoglycemia or land up in the emergency with a hypoglycemia. But at the same time, we would want our patients to have better HbA1c control, because again, better HbA1c control short term could lead to better COVID outcomes if unfortunately a patient was to contract the infection. And of course, long term, it would lead to better vascular outcomes as well. So I think pandemic or no pandemic, if we consider the present times, you could call them the new normal or the new abnormal. We have data that U300 glargine provides better glycemic control or similar glycemic control at the worst, with definitely a lower risk of hypoglycemia compared to U100 glargine. So I think the onus is on us to identify patients who would do better in terms of lower hypoglycemia and better glycemic control when shifted from U100 glargine to U300 glargine. So I end my part of the discussion there, and I'll take up questions if they are there to answer. Thank you.
Hello. Hello.
Hello.
Yeah, Dr. Mridul Viral. I have a question.
Mm-hmm.
Do you think that this is as it is a concentrated insulin is the Tosio, that is insulin glargine 300. Do you think the Tresiba 200 it will be a better option or better competitor for this Tosio?
I think that there is a trial called the Conclude trial where U200 degludec was compared to U300 glargine. But at this point of time, U200 degludec is not available in India. But even for a theoretical discussion, the Conclude trial failed to meet its primary endpoint, which was a difference in symptomatic hypoglycemia between U200 degludec and U300 glargine. So in terms of a better lowering of hypoglycemia, we have the Conclude trial, which failed to meet its primary endpoint. And of course, in terms of efficacy, we have the Bright trial, which was, however, U100 degludec versus U300 glargine, which showed similar efficacy. So the only data we have with U200 degludec, the Conclude trial, does not show any benefit of U200 degludec over U300 glargine.
Okay, thank you.
Hello. Dr. Goswami, is it due to the albumin binding characteristics of these two different insulins?
I think that is a point in certain patients, not all patients, but patients who have an albumin of less than 3.8 could be due to renal disease, liver disease, or chronic ill health. In them, there is data, although the studies are small, 30 patients, 40 patients, which suggests that with degludec, because of its albumin binding property, there could be the greater risk of hypoglycemia in patients with hypoalbuminemia. So that is an area where we have to be on the lookout. These are small data, not big data, but we have to individualize based on the albumin level.
Thank you.
Thank you, Dr. Somik Goswami, for your wonderful lecture and practical tips that how to give U300 when from changing from U100 to U300. So this can save the patient from hypoglycemia. Thank you.
Thank you.
Thank you.
Thank you. Hello.
Yes, yes, sir. Carry on.
Yeah. Our next topic is adult vaccination in type 2 diabetes, and our speaker is Dr. Somnath Naskar, who is Associate Professor of Community Medicine at Bardhaman Medical College. He is having 24 publications in national and international journals, and we see that apart from micro and macrovascular complication, diabetic patient is having more infections. Infections are also 2 to 4 times more in diabetic patients. And adult vaccination, we are in India, we are lagging very behind in adult vaccination. Pediatric vaccination we are doing, but now we have got so many good vaccines: pneumococcal vaccine, influenza vaccine, hepatitis B vaccine, and also some other vaccine which we can use in adult to reduce mortality and morbidity related to infection in diabetes. So I welcome Dr. Somnath Naskar to elaborate on the subject of adult vaccination in diabetes. Over to you, Dr. Naskar.
Thank you, Dr. Bansali, for your kind words. Good evening and happy Independence Day to everyone.
Good evening.
Good evening. At the outset, I want to thank to the organizers and to the August audience. And if we all can remember, this is the day, the 15th August, for which our Honorable Prime Minister was supposed to give the nation a long-awaited vaccine against COVID-19. But the task was not easy, or rather it is too difficult to attain. I'll touch upon this in the later part of my presentation. Now, diabetes, as we all know, it is considered tough for its macro and microvascular complications. And all our focus is on that part. And it's rightly so, but in doing so, many of us probably ignore another facet of it. Or in other words, we miss another opportunity. That's the infectious disease, which claims much importance in developing country like us. Poor glycemic control makes people more susceptible to the infections, and the infection in turn worsens the glycemic control, and the vicious cycle continues. Some important infections in diabetes are like respiratory infections like pneumonia, influenza, tuberculosis. Urinary tract infection is very important, foot ulcers, and other skin infections. Now, okay, so let's focus on the pathophysiology of diabetes. We all know it. So let's have a quick brush up. It's fine. The pathogenesis of diabetes is multidimensional. Humoral immunity is very much affected. There is reduced cytokine functions, mainly deficiency of cytokine 4, and in turn there is reduction in neutrophil function. There is the cytokine functions are also impaired, and in turn it leads to reduction in T lymphocyte responses, and in turn there is reduction in or inhibition of interferon gamma, TNF alpha, and all these things. To add on to this, there is glycosuria, there is gut dysmotility. There are other factors as well, like angiopathy, increased risk of hospitalization, and for that there is increased medical procedures also. All these add up to increased frequency of infection and increased severity of infection also, and that may lead to increased antibiotic resistance. So elevated blood glucose exposure of pulmonary epithelium leads to increased influenza virus infection. It is shown by Ohio and Adamson. Now, the most important part among this is most of the infections, most of them, may not be all, are preventable. So like Louis Pasteur said long ago that when meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. And this is very much pertinent and very much relevant in this era also. Now, when we talk about immunization, for most of the people, for layman, it's for kids only. But no, it's not only for the kids. It's for the vulnerable populations, like children up to 5 years of age, pregnant women, the elderly population, the healthcare worker like us, and the individuals with chronic medical conditions like diabetes. And this is the focus of today's discussion. Now, vaccines are one of the most successful public health initiatives ever, and that is well accepted, and the whole world can appreciate this. Now, some success stories of vaccination are like smallpox was eradicated in 1978 from India and from the world in 1980. Polio has been eradicated from India. The prevalence of diphtheria, pertussis, tetanus, measles, mumps, rubella, all have been reduced over time. This is one landmark paper showing the recommendation for vaccination for diabetic patients in India, showing pneumococcal vaccines, 1 or 2 doses, influenza vaccine, 1 dose of trivalent influenza vaccines annually. Will come in details of this in later part of my presentation. Tetanus, diphtheria, and pertussis vaccines, 1 dose, and then TD vaccines every 10 years. It's given intramuscularly. MMR vaccine, 1 or 2 doses. It's given subcutaneously at 4 weeks interval. Varicella, 2 doses, at least 4 weeks apart. Zoster vaccines, 1 dose for people of 60 years and above. Hepatitis B is very important in diabetic background. 3 doses of hepatitis B vaccines at 0, 1, and 6 months. HPV vaccines, 3 doses through age 26 years at 0, 1, and 6 months. These are the recommendations given by CDC. CDC says that influenza vaccines, pneumococcal vaccines, hepatitis B, zoster vaccines, and Tdap vaccines are important for diabetic patients. Now, why do we vaccinate people for influenza. The study shows that people with diabetes are 6 times more likely to be hospitalized for influenza. And on account of change in circulating strains, the antigenic drift and waning immunity, yearly revaccination is required. The influenza vaccines largely have two types. One is live attenuated and another one is inactivated vaccines. The live attenuated one is given intranasally and the inactivated one is given intramuscularly. And intramuscular vaccines are further divided into the split vaccines and the subunit vaccines. Now, the inactivated vaccines are of again two types: the quadrivalent and the trivalent vaccine. The quadrivalent vaccine consists of 2 strains of influenza A and 2 strains of influenza B, while the trivalent vaccines contains 2 strains of influenza A but 1 strain of influenza B. But the cross protection offered by the 2 influenza B lineages are limited. Therefore, it is better, it is advisable to provide, it is advisable to give quadrivalent vaccine instead of trivalent influenza vaccines. So the comorbidities as well as advancing age or risk factors for pneumococcal disease. The study has shown that diabetics have 3 times more risk of death compared to the non-diabetic counterpart. Type 1 and type 2 diabetes have 4.4 and 1.2-fold risk of hospitalization compared to non-diabetic. HbA1c of, if it is more than equals to 9%, there is 60% risk of hospitalization. But what is more important and what is most interesting is that even if the HbA1c is less than 7%, the risk of hospitalization is 22% more compared to the non-diabetic subjects. Now, there are 2 types of pneumococcal vaccines. One is polysaccharide vaccine, another one is conjugate vaccines. Polysaccharide is PPSV23 and the conjugate vaccines are PCV13. Now, the polysaccharide vaccine is T-cell independent, while the conjugate vaccine is T-cell dependent one. PPSV23 stimulates B cells to produce antibodies, while the PCV stimulates T cell to help the B cell to produce antibodies, and in turn there is some memory also there. Now, for people of 19 to 64 years, it is recommended to give PPSV23 if they are diabetic, and 1 dose intramuscular, 1 dose is given. And if the person is 65 years or older, PCV13 and PPSV23 need to be given. And if these 2 need to be given, that these 2 vaccines should not be given on same visit. Preferably PCV13 should be given earlier, and after that, after 1 year of that, PPSV23 should be given. And if the person is more than 65 years, 1 dose of PPSV23 should, the person should receive that irrespective of the previous immunization before 65 years of age. Now, hepatitis B is a very important vaccine, that a very important disease, and the people with diabetes should receive the vaccine, because from that landmark study by Dr. Kesavadev, Jyoti Dev, Dr. Bansi Sahu, Dr. Shashank Joshi, it has shown that diabetics are 2.1 times more risk of having hepatitis B infection, and hepatitis B virus can be transmitted by medical equipments, and as there may be chances of more hospital admission and more medical procedures. From that, the person with diabetic can have the hepatitis B infection. Therefore, ACIP has recommended, that is advisory committee for immunization practice and CDC, they have recommended that hepatitis vaccine, the every person with diabetes, they should receive the hepatitis B vaccine at the earliest as possible. There are 3 doses of hepatitis B vaccine at 0, 1 and 6 months, and it should be given intramuscularly.
Somnath,
Yes.
can you hurry up a little bit because we are running late?
Okay. So for zoster vaccine, as we know, diabetic is a chronic inflammatory and immunocompromised state. There is chances of reactivation of varicella zoster. Therefore, this vaccine should be given. And there are 2 types of zoster vaccine. One is live attenuated and another one is recombinant zoster vaccine. So among that, recombinant zoster vaccine is preferred and a single dose of recombinant zoster vaccine is recommended. Other vaccines I have already discussed. I'm just skipping this. Now the most important one, I mean, not the most awaited one. The people, the world is eagerly waiting, desperately waiting for this vaccine against COVID-19. But there's some challenges, there's some issues. So now, preclinical experience with vaccine candidates for SARS and MERS have raised concerns about exacerbating lung disease, either directly or as a result of antibody-dependent enhancement. Now, as it is not very clear that natural acquired infection, the immunity offered by the natural acquired infection, the duration of that immunity, as it is not very clear, it is also not very clear whether a single dose of vaccine will be sufficient or more doses will be required. And in a pandemic situation, when a fast track vaccine has to be incorporated, has to be introduced, some steps have to be run in parallel rather than sequentially, without confirming the success of the previous step, and which causes elevated financial risk. Now, the COVID-19 vaccines that are in pipeline, in phase 3 clinical trial, there are 5 vaccines from China, UK and USA, with no serious adverse event following immunization, only fever, malaise or headache. In phase 1 or 2 clinical trial, there are 9 candidates. Among that, there is the candidate from the vaccine from Bharat Biotech. There are 2 doses. The 2 doses are supposed to be given intramuscularly at 0 and 14 days. And there are 142 other candidates in preclinical trial stage all over the world. Now, standards for adult immunization, the vaccine should be available. The patients, before giving the vaccines,
Somnath, you have to conclude.
Please. Okay. Previous immunization status has to be known, and the communication with the patients is very much important. So, to summarize the thing, provide routinely recommended vaccines for children and adults with diabetes, annual vaccination against influenza for people of more than equal to 6 months of age, vaccination against pneumococcal disease, including pneumococcal pneumonia by PCV13 and PPSV23, whichever is required or recommended by the guideline. Hepatitis B vaccination is very much important. The 3 doses should be given at 0, 1 and 6 months intramuscularly. The tetanus, diphtheria and pertussis vaccine once, and then TD every 10 years. MMR vaccine 1 or 2 doses, 4 weeks apart. HPV vaccine 3 doses, and single dose of recombinant zoster vaccine has to be given. Now, be wise, immunize, that is the tagline. Thank you all.
Thank you.
Thank you, Dr. Naskar, for elaborating all adult vaccine which we can use in our day-to-day practice. Now I invite question if there is anyone.
I have one comment. Hello, can you hear
Yes,
me?
Dr.
Somani. Yeah, carry on.
There is some regarding COVID and vaccination. No? There is some interest in MMR vaccination because rubella shares some 30% similarity with COVID-2 virus. and there is some interest in BCG vaccination also in COVID. BCG give rise to a diffuse and non-specific immunomodulation upwards. These two may help. Some of our colleagues from South, they claim they have taken MMR vaccines. This is just for information.
Thank you, sir, for your comments.
Because fusion protein and these proteins are spiky proteins, fusion proteins,
Because,
between those they share 29% similarity.
Somnath,
um,
can you hear me, Somnath?
Yes, yes, sir.
I just want to ask you the pneumococcal vaccine, the recent one which has come as a conjugate vaccine. Now, do you need to repeat a polyclonal vaccine after a conjugate vaccine, or the conjugate vaccine is good enough to give a lifelong immunity in case of pneumococcal vaccine?
No, for pneumococcal vaccine, if PCV13 can be given, but after 1 year, a PPSV23 has to be given.
Yeah.
In case of there are some different situations. For renal disease, it has to be given. Another
No,
dose
for
of
renal disease, we are repeating it after 8 weeks. Yes. A normal situation, but there is a different school of thought. Some say that it may not be required because of the recent vaccine. We have to wait for further trials to understand the vaccine's immunity, whether it progresses or we have to repeat the polyclonal vaccine.
if a child has received PCV vaccine, already have received PCV vaccine, then this PPSV 23 will be enough. But in our country, most of the children, they don't receive PCV 13 vaccine. So we require PCV 13 first and followed by PPSV 23 1 year later, as explained by Dr. Naskar.
Yes, it is preferable to give PCV 13 first, then after 1 year. And in some situation, it is said that after 8 weeks, it is given, where there is 2 doses of PPSV is required, and another dose of PPSV 23 is given after 5 years. In normal situation, PCV 13 followed by after 1 year, there is one PPSV 23.
Somnath, I have the last comment about the PCV 13. The recommendation by the international guidelines, you have to give the PCV 13 at least 1 dose for every individual as the patient ages above 65 and older. But the new guideline for the Indian government is, if the patient is above 50 years age, you have to give the PCV 13 for the Indian patient also. And after that, you can, if the pneumococcal, you want to give the patient another booster dose of pneumococcal vaccine, you have to give the PPSV. And that should be 1 year, 1 year gap.
Okay, before 65 years, if the person have received any PPSV, okay, I agree with you completely. And after 65 years, if the patient have received PPSV before 65 years, after 65 years, another dose of PPSV 23 is required, and the gap should be 5 years between the first dose and the second dose. Thank you.
Thank you. We should conclude.
We should conclude the
Thank
session.
you, Dr. Naskar, for elaborating about all the adult vaccination, and you have nicely explained about pneumococcal vaccine as well as upcoming COVID-19 vaccine and its difficulties. And if there is no question further, I declare the session closed. Thank you.
Thank you.
Thank you, doctors. And with this, we move on to the second scientific session of today's evening, that is remission of diabetes, what's new, and female sexual dysfunction in diabetes. And I would like to welcome our moderator for this particular session. It's my pleasure and honor to welcome one of the patrons of HDS, Professor Dr. Arun Majumdar, who is a senior physician of internal pediatric medicine, and he is an ex-HOD of Medicine Medical College, Calcutta. We welcome you, sir, on behalf of HDS. Over to you, sir.
Good evening. I think it is my pleasure to be here on this very auspicious day to have this involvement in this conference of Howrah Diabetes Society. It's my pleasure, and I find it very interesting. I find my very colleagues here. I think we have got time constraints. We're already late. So without wasting time, I will pass on to the topic directly. Before that, I must congratulate the scientific committee for giving us this beautiful apron and the beautiful dress code. We enjoyed this dress code. And I must congratulate the organizing committee for giving this opportunity to be here.
Thank you, sir.
Now, our topic is, I also feel very happy that we have got a topic on COVID in this era of COVID. Now, I will request Dr. Indira Maisnav. I think Indira is well known to all of us. She is a very young and dynamic endocrine diabetologist of Calcutta and also Howrah also. She is known to me and also many of us. She will be talking on he will be talking on mainly the remission of diabetes. What is new? I think we are all very much inclined to hear from her whether cure is possible or remission is possible. Over to Dr. Indira. I will request Dr. Indira Maisnav to start her deliberation.
Thank you, sir. Respected chairperson, learned delegates, it's indeed a great honor and my pleasure for me to be delivering this talk in this August gathering. And I congratulate the organizing society for such an excellent program. And it's also indeed a great pleasure and a privilege for me to have my session chaired by none other than Professor Arun Majumdar, whom we know as an icon and as a wonderful, excellent doctor and as well as a teacher. So my topic today is remission of diabetes, what's new? So the first hint that type 2 diabetes may be reversible actually came from bariatric surgery in this article in 1992 by W. Porris et al., who found out that 141 out of 163 patients who underwent surgery, bariatric surgery, actually reverted to normal after 10 years. Old age and long duration of diabetes mellitus were less likely to revert to normal. So it was rather extemporaneous finding in the sense that we were not prepared for it. When they went in for bariatric surgery, what they intended was to bring a weight loss. But over the years, they found that there was also a remission of diabetes. And now we have numerous papers in bariatric surgery and diabetes remission, which, for example, in this Nature Gastroenterology review, we see that the remission of diabetes was much more in bariatric surgery, now known as metabolic surgery, compared to medical therapy. But at the same time, we are also aware of the limitations of bariatric surgery. And I think till proper pharmacotherapeutic means is available, maybe bariatric surgery can be used as a standby, but then bariatric surgery is also associated with long-term as well as short-term complications. Now, sir has, as the chairperson has pointed out, is it remission, is it reversal or cure? So cure is the restoration to good health. So somebody, let's say, had a bacterial pneumonia now and was incapacitated, now has become all right. So it's cure. So cure is applied more in the context of acute illness. But cure cannot be applied in the context of chronic diseases like diabetes, like atherosclerotic cardiovascular diseases, etc. And it's better to use the term remission because remission is free of signs and symptoms of the disease, but then the word is used because there's always the possibility of recurrence if there is a re-emergence of the risk factors. We're also aware of the fact that hyperglycemia exists along a continuum and the cutoffs of diabetes are based on the diabetic specific complication, that is retinopathy. So what does the absence of diabetes mean? Does it mean a normal glucose or the correction of the pathophysiology? I think we are not in a stage right now to correct all the pathophysiological faults of diabetes, and what is used to define remission is actually a glucose-based value. And thereby, the American Diabetic Association in 2009 gave the definition of partial, complete, and prolonged remission. So partial remission means the patient is not diabetic, but has some degree of hyperglycemia. So we can call it pre-diabetes with at least 1 year of duration without any pharmacological therapy. Whereas complete remission means patient is normally having absolutely normal blood glucose, at least 1 years of duration without any active pharmacologic therapy. And prolonged remission means if this remission can be maintained up to 5 years duration. So coming more to the bariatric surgery, in this this study in Sweden, what they did was that they took patients who they maintained a very good registry, as we know, and this Scandinavian obesity surgery registry took into account patients who underwent bariatric surgery and who had diabetes, and all of them had a BMI of more than 35. These were the people between 2005 and 15 who underwent the surgery, and they tried to find out at 2 years and 5 years what was the remission. So for 2 years, the remission was good, still good at 58.2%, and at 5 years, it was 46.6%. And the chances of remission were lesser in those with a longer duration of diabetes, older age, high baseline HbA1c, and insulin treatment. And remission in this group was more in males and in those with a higher baseline BMI, telling us that the weight loss actually helped in the remission. And if we see the proportion of, in the same study, the proportion of patients free from medications 2 and 5 years after surgery, we see that when somebody is having diabetes for more than 26 years, the chance of remission was very low, around, let's say, almost next to 0%, whereas when somebody was having a diabetes for less than 1 year, the remission was more than 90%. We also see that the chances of remission was lesser at 5 years compared to 2 years, where the remission was more, which is the blue line. We are also aware, we are somewhat aware, I would say, of the mechanism of diabetes remission following bariatric surgery. And to tell it briefly, it is because of intense calorie restriction. It is because of the alteration of the incretin profile that is deranged in diabetes. It's also the alteration in the gut microbiota and alteration of the bile flow. And then interestingly, this paper has been, this group, Dr. Roy Taylor and his group has been making a lot of, let's say, interest in the recent years. This is about the ectopic fat. So this is a twin cycle hypothesis of type 2 diabetes. So according to this group, they believe that the ectopic fat in the liver and the ectopic fat in the pancreas are responsible for diabetes. So when there is a positive energy balance because of energy excess, there is increased fat in the liver. When there is increased fat in the liver, there is increase in the hepatic glucose output. And this has to tell the pancreas to secrete more insulin because there is hepatic insulin resistance. At the same time, the increased fat in the liver also increases the triglyceride, that is the VLDL triglyceride in the circulation. And this, we know the triglycerides are deposited in the subcutaneous fat, but also in susceptible individuals, they are deposited in the pancreas as islet triglycerol, and this can result in the dedifferentiation of the beta cell. Thereby, this would result in an insulin response to glucose that is diminished, and thereby increase the postprandial hyperglycemia, increase the insulin secretion, and the vicious cycle goes on and on. So this group believed that if you cut this cycle, if break this cycle by means of intense calorie restriction, maybe you could reverse diabetes. So they had this proof of concept study, which was which they did in a small group of individuals with type 2 diabetes. It was 11 people. They gave them intense calorie restriction, around 600 kilocalories a day, and then they looked at the normalization of the beta cell function, the insulin sensitivity. They even looked at the pancreas and the liver fat by means of MRI, and what they found was that the normalization of both beta cell function and hepatic insulin sensitivity in type 2 diabetes was achieved by intense dietary energy restriction alone. So they wanted to further go research on this and had these two studies known as the counterpoint and the counterbalance study. So the counterpoint study took place in patients who had type 2 diabetes of less than 4 years. Again, they took 11 people, and their target was to lose at least 15 kgs of weight. And when these individuals, all of the individuals lost 15 kgs of weight, and at 24 weeks, it was seen that they had 100% remission of diabetes. Now they wanted to see whether it could apply to people with longer duration of diabetes and also for a longer remission. So yes, they took patients who were having diabetes as high as 23 years, and they wanted to see whether it was sustained even at 6 months. So some patients responded to weight restriction, whereas some did not, as we can see here, because the minimum weight restriction decrease that was required was 15 kgs. And here also we see that even in patients in this group of individuals where the duration of diabetes ranged from 0 to 23 years, around 43% went into remission. And then they went on to study a very big study known as a direct study, which was very much talked about. It came in the local press, it came in the layman, in our journals, and also in the layman press, where they took this concept to the primary care. So this was done in UK in a completely Caucasian population, and where it was an open level cluster randomized control study, and they took individuals aged 67 years, less than 6 years, and with diabetes less than 6 years, with a body BMI of 27 to 45 kgs per meter square, and they were not receiving insulin. Again, they were subjected to intense calorie restriction via diets, which was as we can see here, the total diet replacement was only 800 kilocalories per day. And then if there was a regain, again, there was restriction. So through this complex procedure, they found out that at 1 year, so this was what happened to 1 year. It was 1 year, 24% of those in the intervention group lost more than 15 kg, and 46% in the intervention group at 1 year had remission of diabetes. Now, it was seen that the remission of diabetes was a function of the degree of weight loss. So when there was weight loss of more than 15 kg, then the remission was seen in 86% of the individual, whereas when the weight loss was less than 5 kgs, the remission was seen in only 7% of the individual. Again, they went one step further to see this direct trial, to see if they could do it in people who are having even longer duration of diabetes, let's say 2 years. And that's what they found, that if you could maintain the weight loss, then the diabetes can still be into remission. The problem is that it is difficult to maintain the weight loss at that time. So we see that at 2 years, only 11.4% of the individual had weight less than 15 kg, and thereby the numbers who were in remission actually decreased. But again, at this point in time also, the numbers, the people who would be into remission was a function of the degree of weight loss, where we see that when there is more than 15 kg weight loss, even at 2 years, the remission rate was 70%. So again, whatever we do, it has to be cost effective. So this was a simulation model where they tried to find out whether it is cost effective, whether the prevention or the remission of diabetes is cost effective. And what they found was that over a lifetime horizon, the direct intervention is predicted to be more effective, and not only cost effective, but cost saving, because of the fact that diabetes is being postponed and thereby the complications are postponed. But then there are some things we have to look into, because this direct study, what we see is that it is for long-term weight stability. It has to be a contribution by everyone, the patient, the family members, the friends, the medical team, etc. Patient has to be active about self-monitoring of weight, should agree to the weight threshold, should modify the microenvironment. What is the type of food in my house? What is the type of food in my fridge? Patient have to know the knowledge about the food choices, portions, etc. Even know about cooking skills and activity, and what to do and how much to do. And certain food for thought is that we know that 72% of people with BMI more than 40 kgs per meter square do not have diabetes, and a large number of patients with type 2 diabetes have a BMI less than 25, which is very, very common in our country. And if we see at the studies of diabetes reversal with weight loss, it was those who had a BMI of more than 27. And even in the direct study, there were some individuals who had a BMI more than 30, which is obesity by Western criteria, still went into remission. So this tells us that every person has a personal fat threshold. So to put it in simple terms, the personal fat threshold is that how much fat the person person can hold in the subcutaneous adipose tissue so that it does not overflow to the ectopic sites, resulting in the metabolic complications of obesity, including diabetes. And we Indians are known as the thin fat Indians, where we have a low subcutaneous adipose tissue mass, a low muscle mass, but then when we gain weight, we do so in the visceral or the central side. And this is to do with epigenetic programming. That is a type of environment which we are exposed to in the early lives. It could be as early as intrauterine life, because the maternal malnutrition can result in a thrifty phenotype and result in easy development of diabetes. Again, other than this, are there any concepts other than weight loss? So here, this was a study which came as early as recently as in August 2020 by the most renowned journal of endocrinology, that is a Journal of Clinical Endocrinology Metabolism, where they tried to see if intensive glycemic control in the early years with the use of insulin glargine, metformin, and dapagliflozin. This was known as the DAPA-REMIT study. Did it result in the remission of diabetes compared to the standard of care? So what they found out, because many times we have seen also that patients come to us with, let's say, steroid-induced diabetes with blood glucose ranging from 300 to 400. We give an intensive management, and many of them are almost in remission in the sense that they're only on lifestyle or on metformin. But in this study, what they found out was that no, the diabetes remission was not different between the standard of care compared to this intensive treatment group. But yes, some patients with early type 2 diabetes were able to achieve the sustained diabetes remission following a short-term intensive intervention, telling us that yes, we have to identify those group of individuals who may benefit by this intensive intervention. So now let's say the patient is in remission. Now what? So should we call him or her normoglycemic? I think we cannot call them normoglycemic because of the fact that the patient always is at a risk of diabetes. So is the term post-diabetes better? And we are all also aware of the fact that this remission of diabetes has to do with the glucose. But we all agree nowadays that diabetes is a comprehensive treatment and not only a glucose-oriented treatment. So what do we do to somebody who has gone into remission? What about the screening for the complications? What are the evidences and what are the recommendations? Yes, the ADA came up with a recommendation in 2009 where they said that if the patient has been in remission of less than 5 years, then we would screen for the routine complications of diabetes as we would do in somebody who currently has diabetes. But if the patient is in remission of more than 5 years duration, in that case, we may decrease the duration of screening for complication, provided that the patient does not have those complications. But many of these patients could already be having, let's say, a macrovascular complication or others. So to summarize and to conclude, type 2 diabetes may be kept in remission in some people, but not all. I think we have a vast pathophysiology of diabetes. Currently, the weight loss is the most easily understood mechanism of remission. But remember that this may not be easily applied to the Indian population because of the fact that we already have a low BMI, and the people who underwent weight loss and went into remission had BMI of more than 27. And the direct study was a fully Caucasian study, and therefore it cannot be directly extrapolated to our population. What is available is remission and not cure. And remember, it's not a cure is not a cure and forget case. Remission is not a cure and forget case. Many times patients have asked us because they have seen in the newspapers and other, can I go into remission? The purpose of them wanting to go into remission is that they want to stop caring for their health as they would do when they're having diabetes. But we have to explain to them that the effort that is given for diabetes remission is actually more than the effort that they have to give for the control of diabetes with pharmacotherapeutic agents. And the chance of relapse is a possibility if the weight control slips. And I have already talked about the diabetes-related comorbidity, which will have to be looked into, that is the microvascular and the macrovascular complications, even in those in remission. So there are possibly many facets of type 2 diabetes remission. We are understanding some of it. One of them is the weight loss, that is intense weight loss. One of them is the bariatric surgery, which is telling us about the various signaling that the alteration of the various signaling that occurs in our brain and the correction of those with bariatric surgery. But what I can say at this moment in time is that we are just beginning to understand. Thank you.
Okay. Thank you. Yes, I think it was a very excellent talk by Dr. Indira. You have nicely elaborated what is remission. That means the patient has the idea that it is perhaps an irreversible process, but even without medicine, the patient can be managed for some time. So it's a concept which is coming up, but there are a lot of questions, lot of comments also, but I think within time concept is very difficult. As for example, I tell that it is more of a lifestyle, definite to weight loss, but also the dietetic history is very, very important. And about the various pharmacological agents like GLP-1 analogs, very early insulin therapy in the initial stage, and even a type 2 without any glargine, etc., etc. So perhaps can retard some disease process. But what is very important is the early diagnosis, early intervention, even at the pre-diabetic stage. Now about type 1 diabetes also, similar things. Yes. Also, the role of vitamin D also will be coming up. So it's a multi-disciplinary problem, I think, but it's definitely, yes, a new concept. There is hope, but we must follow them up, what happens after as well.
Type 1 diabetes,
okay,
also,
thank you.
remission is about the islet cell transplantation.
Yes,
in
yes.
Type 1 diabetes islet. So that is also, but that is another issue. So I didn't take up because, yes, it was 12 minutes.
Exactly, I do appreciate. But yes, I think early insulin therapy and also the various monoclonal antibodies targeting these. Yes, so yes. It's a broad subject. I do appreciate, no doubt about that. Now, any comments or any questions from our distinguished members of the audience?
Please invite the next speaker, sir.
Yes. Hello, any questions or?
Sir, leave question now, please.
No, sir, audible.
Hello.
Indira, can I just ask you, do you recommend the special diets for your patients with diabetes? It's nothing to do with remission, but in everyday life.
So again, there is another very vast and very debatable and controversial topic. But ultimately, what matters is the calorie restriction and also not taking avoiding refined carbohydrates, taking complex carbohydrates, a balanced diet. There are many diets. There are many studies on it. We have data on their effect on, let's say, short-term weight control, but we do not know the effect of those in the many years that would follow. So at present, I would say a calorie restricted diet that is, yes, having carbohydrates, but in the complex form, balance in protein and fat, and with lots of this one, vegetables and others. So no specific diet. I don't specify any specific diet to my patient, like Mediterranean or Atkins or anything like that.
Thank you.
Yes.
Dr. Indira,
yes,
Dr. Bera, can I have a question?
Yes.
The recently concluded trial in the DAPA heart failure that has been seen the use of dapagliflozin in the pre-diabetic patient.
Yes.
And that has been in the pre-diabetic patient, the dapagliflozin has been used by the exploratory data has been seen. That group of patients that was dapagliflozin has been used, that the least number of patients fall into the diabetics. And that means one of the facets of the use of dapagliflozin in pre-diabetic patient, that you can say that it can cause some remission of diabetes. What is your opinion?
Actually, we'll have to have a washout period because of the fact that it could be that dapagliflozin was actually treating the pre-diabetes. It could be that rather than preventing, making it go into remission, it could be that dapagliflozin was actually treating the pre-diabetes. So we'll have to, after the use of dapagliflozin, to see whether it effect is sustained, we'll have to have a washout period, we'll have to have a follow-up, only then we can say. But theoretically, it is possible. Theoretically, is possible because it alters the adipose tissue distribution and also amount in our body. So that's why this paper, which I referred to in the JCEM, that DAPA REMIT trial was also done, because it has a favorable effect, not only in the adipose tissue composition, but also the distribution.
One question.
Yes, sir.
Indira, about your vitamin D replacement. Have you got any comments on that? Vitamin D.
Sir. Okay, so vitamin D, so there are many papers on it. In fact, my research topic was also based on that. So the thing is that, and it was, in our study, at least in our study, we showed that in patients with pre-diabetes, if they are supplemented with vitamin D, and those who are vitamin D deficient, if they are supplemented, then they prevented the progression to diabetes. So yes. Again, sir, so again, we cannot say this is the right thing, because there are people who have other papers who have also pointed to the contrary. So right now, we cannot say that it is the treatment for the remission of diabetes, but yes, there are evidences for and against it, even in patients with type 1 diabetes, because of the at risk of type 1 diabetes, because it is also associated with the modulation of immunity.
And what are your comments about GLP-1 analogs?
So, say again, sir, it is the concept of the bariatric surgery also, because what the bariatric surgery is doing is improving the incretin profile. Other than the weight loss, that is because of calorie restriction, there is also the improvement in the incretin profile. Yes, the GLP-1 receptor agonists, along with others, are coming up in a big way for the, let's say, treatment, rather than the remission, for the treatment of both diabetes and obesity. So like we have something known as a triagonist that is coming up, which takes into account GLP-1 receptor agonist, GIP, and glucagon. Glucagon is supposed to cause weight loss, but at the same time, it causes hyperglycemia. So the GLP-1 and the GIP would address the hyperglycemia, and the GLP-1, GIP, and the glucagon together, known as a triagonist, would address the obesity and thereby address the let's say, the pandemic of diabetes. So yes, it is there, but regarding reversal, again, there are papers, there are certain papers on remission, but then not very large studies, I would say. But
just
yes,
just one point.
Thank you, sir. Can we move on? We are running late. Indira,
okay.
Thank you very much.
Okay, Indira.
Yeah, thank you very much.
So I think thank you once again for giving us, enlightening us on this very important topic. So we'll pass on to the next topic. Dr. Subhash Mukhopadhyay, I think he is well known to all of us. Very academician, obstetrician, gynecologist. We are often hearing him various lectures in various occasions. He will be talking us today on a topic, female sexual dysfunction in diabetes. I think usually we talk about the sexual dysfunction in males, like erectile dysfunction. So this topic is somewhat new. So we'll be enjoying this talk on Dr. Subhash Mukhopadhyay. Dr. Mukhopadhyay, please.
Respected Chairperson, sir. Respected Chairperson, sir. My friends, colleagues, ladies and gentlemen. At the outset, my very sincere thanks goes to Howrah Town Diabetic Society for giving me the opportunity to share a platform where I can share my few views. As Sir said rightly that I'm interested in academics, but to be very honest, I am not a very good academician. I am really very happy to see you all people in this present COVID-19 context, where people are, staying inside, not coming out, not seeing their friends, not socializing or whatever. And actually we're running short of time, so I should not be taking much time. I just want to share a few views that when Dr. Sanjay Shah asked me to talk about something, female sexual dysfunction in that. I thought, oh my God, I don't have any idea about it. But honestly, as respected Dr. Mojumdar said, that lot of works has been done about male sexual problem rather than female sexual problem. And that is probably because of our background, because of our country, because of our whatever situation. So to start with, can I have my first slide, please? Yes. Female sexual dysfunction in diabetic problem involving both psychological and organic factors. As Sir said very nicely, that mostly studied in males, female sexual dysfunctions are not highlighted that much in literature. And actually, let me be very honest with you. I was going through the literature and searching, but not much work has been done, even in the Western literature. And in our country, I really couldn't find much work, maybe one or two sporadic reviews. So basically, I'm talking about this subject, but if I am really very honest with all of you, I really do not have much idea because I am not that specialist, as you said, a sexologist. Thing is that sometimes we come across that in our infertility clinics, that they talk about kind of sexual problems, but most of the times, as we are obstetricians dealing with obstetrics and gynecology, and particularly in the older age group, like menopausal, perimenopausal patients, they do not like to talk about their problems, and most of them are undiagnosed. And mechanisms are different, not involving autonomic nervous system and vascular system that are more likely in males. And interestingly, the duration of the disease is not directly proportional to the severity of the disease. It's fairly common. Prevalence is around 51%, well, to be honest, 41 to 64%. Next slide, please. Yes. Now, as I said previously, that concentration has been more on problems like infection, menstrual disorders, contraception, HRT, and other female health problems rather than their sexuality. And problems with pregnancy and childbirth has taken a vast majority of diabetes, and sexual dysfunction is not regarded as a problem in these situations by very many of us. There are predictive risk factors in the sense that, okay, you are suffering from diabetes, so you may be having that kind of problem or you may not be having that kind of. There is no predictive factors and one really cannot predict. And we, as I said, that we come across few problems in our infertility clinics. And as a matter of fact, that if I have to pinpoint how could I associate diabetes with sexual dysfunction, there is not really a very direct link. It is multifactorial and it is also psychosomatic. Next slide. Now, the type of dysfunction in females we come across, that mainly decreased arousal, inadequate lubrication and dryness, that is one of the very common thing and causes problem. Decreased sexual desire. It is very important that most of the patients, if we say them patients, whatever, that their desire is actually low. They don't really feel like, and that has got a lot of problems like their age, their familial background, their occupation, their jobs, and whatnot. But majority have got lower sexual desire. Dyspareunia is a very important factor, and loss of ability to reach orgasm. And it has been found that it is significantly higher in menopausal women, which is probably one can assume that because of menopausal or perimenopausal lower hormone, their desire and other sexual functions may be lower. And as I said, that incidence varies from 41 to 64%. Next slide, please. Now, assessment and dysfunction of the diagnosis. I think I should be speeding up rather than talking, taking much time. So I should
Only
for the next slide, please.
6 minutes 30 minutes. 6 minutes 30 seconds.
Yes. Now, if somebody asks me, okay, doctor, how would you diagnose sexual dysfunction? Is there any biomedical, biochemical, or whatever parameter that, okay, there are sex protein A or sex protein B or whatever. If there is less, there is sexual dysfunction. If there is more, there is no dysfunction, blah, blah, blah. Interestingly, this has been diagnosed by international organization as female sexual function index, and it has been done by a report questionnaire, 6-domain questionnaire with 19 items, where the questions are asked about desire, about arousal, about lubrication, about orgasm, about satisfaction, and about pain, and they're put in a scale, and that scale varies from 1 to 36, and depending on the situation, if the score is 26 or less, then it is accepted that that person is suffering from sexual dysfunction. And the score is more than 26, then it's fine. Now, yeah. Now, if we come to the cause of dysfunction, as I said, the psychological, like poor education, absence of occupation, lower support, age, physical fitness, diet, lifestyle, depression, marital status, metabolic syndrome. Now, about metabolic syndrome, it is interesting to find that we all know what is called metabolic syndrome, like increased abdominal adiposity, low serum HDL, high triglycerides, elevated BP, abnormal blood sugar, any 3 or 4 can cause metabolic syndrome. And it has been found interestingly that in metabolic syndrome, that there is increased incidence of female sexual dysfunctions. And medications like metformin, we take metformin in a very frequent way in diabetes, and that has got something to do with lower sexual desire and things because of lower testosterone and progesterone binding protein. Antihypertensive, diabetic, sedatives, and chemotherapeutics all have got their effects. Pelvic surgery, relationship problem, etc., etc. Yes, next slide, please. Now, coming to the management. Well, the management obviously depends on the cause. And as at the outset, I have said that there is no specific cause which can be designated either organic or psychological. It's a complex problem. It's a multifactorial. So basically, the management should be aiming towards like general improvement of health, which some of our speakers said previously: diet, lifestyle modification, regular physical activity, exercises. In one word, that healthy diet and healthy lifestyle, weight reduction, and other proper care of oneself. Education and counseling, that is important. Sex education, that is a vast subject. I should not be going into elaborating into that. Behavioral techniques, that is important. Like sometimes the behavioral problems can cause this problem, and enhancing stimulation things can modify the behavioral techniques and cause a lot of improvement. Minimizing pain like lubricants, positions, etc. Those are easily understood. And there are few medicines like estrogen, testosterone, HRT, sildenafil. All of has got their effect. But in this respect, I'd like to highlight 2 things. One is estrogen and another is HRT, estrogen replacement therapy. Now, local estrogen sometimes we use to increase the vaginal health, vaginal softness, and decrease the dryness. That is very helpful. And HRT particularly, we should be very careful about giving HRT, particularly in the women who are in the elderly age group, with proper counseling and proper testing and everything. So basically, the general improvement of the health and few medications will help. Next slide. Now, coming to the conclusion. At the outset, as I said, that unfortunately, though sexual dysfunction in diabetes is common, it is also common in our country as well. But unfortunately, that issue has not been addressed very well. And most of us go a bit reluctant in addressing that problem, because most of the times what happens that male sexual dysfunction gets more importance rather than the female sexual dysfunctions. Probably, maybe they are a little bit passive as far as the sexual act is concerned. Now, as multifactorial and involves lots of different factors, and management should be a team approach involving different specialties like diabetologists, endocrinologists, clinical psychologists, psychiatrists, and general surgeons, gastroenterologists, and whatnot. Now, one thing at the outset, I'd say that improvement can be achieved by proper, comprehensive approach, care, and treatment and management. Next slide. And I don't know whether you'd like this picture or not. That lady with a chain behind and in the background of nature, kind of chaining a lady from their sexual desire or function, whatever. And thank you very much for your kind hearing. I would say God bless us all in this difficult situation, in this COVID problem, and let's be very positive. And thank you very much to express my views and share my views with all of you. Thank you.
Thank you, Dr. Mukhopadhyay. I think excellent presentation and overview. Although a new topic, but you have given much justice to the topic. I think we had little idea about this topic. You have got thrown some light on this very important topic. Now, one or 2 points before I put forward for the question here. Number one, I think if I've got a criteria DSM-5, in that 5 criteria, there were some duration of the disease. That means if the sexual dysfunction should be more than 6 months, usually it's not transient. So that is one of the criteria has been put forward in DSM-5. So that was number one. Number 2 comments is your full endocrinological and checkup, as you have rightly mentioned, particularly the prolactin level. Has it got any effect on that? So obviously, I have got any comments from your side, please.
Yes, sir. Thank you. Well, I think, this is quite understood that the dysfunction, if it continues for some time, then obviously the management also varies, and particularly, as you said, prolactin. Prolactin is also very important. Yes, it has got to do with the dysfunction as well. So basically the diagnosis depends mainly on psychological assessment and the questionnaire assessment or whatever. But obviously, we should not be forgetting about the organic things and proper investigations and keeping the patient in a background where we have to deal with the metabolic problem, with other problem, the complication problem, and organic problem, and everything. And once we achieve that, obviously the dysfunction would be much better managed rather than not addressing the addressing the problem as a whole, rather than just doing the psychological counseling and things like that. I completely agree with you.
Another point is about the depression component. DSM-5 also mentioned about the complaint of depression, because diabetes sometimes associated with depression. So that might be a contributing factor. Is it so?
Yeah, definitely. Depression is definitely one of the factors which causes problem. And as we know that that depression has got lot of factors which one should consider. Like it has got something to like depression. Either it is endogenous or exogenous, and there are environmental factors like age, the marital harmony, the family background, their work, their their education, their independence, and whatnot. There are so many factors. Interestingly, it has been found that depression causes sexual dysfunction, definitely. And it has been found that antidepressants, after giving antidepressants particularly, there is a lot of improvement as well. But interestingly, in a very few number of patients, it has been found that in spite of depression, when they're depressed, probably they try to find out some ways to get out of the depression. And some of them has got some kind of interesting increased sexual desire, and they try to get relief from increased sexual activities rather than decrease. But in general, in majority, it is dysfunction, lack of desire, lack of effort rather than increased activity.
Okay, thank you. I think any questions or any comments from the our members,
Sir,
please?
since we are running,
We are running late, yes. So
please do not
go
allow
on.
any questions.
Okay,
Sure.
so I think it was a very nice topic discussed. Once again, I offer my sincere thanks for giving us this opportunity to take part here. And obviously, we should be very cautious about that COVID. Thank you once again.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, doctors. Thank you, moderator, and thank you, speakers. With this, we move on to the third scientific session, that is role of co-formulation insulin in these difficult times and role of incretins in diabetic kidney disease. To observe the same, I would like to invite our moderator for the particular session, who is none other than our patron, Professor Dr. Dasarathi Sarkar, who is a senior consultant physician and endocrinologist. We welcome you, sir, for this particular session, and over to you, sir.
Hello, do you hear me?
Yes.
Do you hear me?
Yes, sir.
Yes, sir.
Yes, you are audible.
Yes, yes, sir. Okay. Thank you, organizer, for the invitation. Also, I have a complaint to the organizer. Because the insulin discovered in 1921, this is the centenary year of the insulin. So, whole world is observing this year. But our organizer, the scientific committee, only allotted half an hour for the discussion of insulin. So there is so many modifications there, so many upgradation of the insulin throughout the 100 years. Just in 1945 to 50, NPH has come, LNT has come in 1951, IZS, insulin zinc GMT suspension. In 1975, there's purity has been increased by monocomponent insulin. 1983, the genetic engineering, the human insulin come by Lilly, 1983. Then 1995, the analog insulin has come with Lispro. In 2000, Naspart has come. Also, the Glargine has come in 1999 to 2000. In 2005, the glulicin, in 2004, glulicin has come. Detimil is come in 2005. And lastly, this degludec has come in 2015. And so many combination has been started from the very beginning with NPH and regular insulin. And now the co-formulation has started. The short-acting analog aspart and the basal insulin, ultra long-acting basal insulin, degludec, they are combined in a co-formulation form. And this is very interesting. It has very low hypoglycemia. Incidence of hypoglycemia much less, and also less nocturnal hypoglycemia. All this part will be covered by renowned orator or president of this HTDSS con, Dr. Sanjay Shah. I invite Dr. Shah to come to the forum. Dr. Shah,
Thank you,
please.
sir. Thank you very much.
20 hours.
Mr. Rao, can you share the slide set for me, please? Thank you, everybody, for joining on this virtual conference. Thank you, Professor Dr. Dasarathi Sarkar. And I think we're going to wait for that 100-year celebration next year. So I'm sure we'll have a completely chock-a-block insulin sort of talk next year. But for today, what I'm going to share with you is the role in co-formulations, which Dr. Sarkar hinted at with regards to these difficult times, COVID-19. Next slide. So the agenda, COVID-19, diabetes and insulin. We look at diabetes and the Indian realities. and then IDEG ASP, which addressing Indian realities during this epidemic. Next slide. Now, perhaps there's not enough data, but the understanding essentially is that people with diabetes and those without diabetes have the same likelihood of contacting COVID-19. Okay, so it will be perhaps very similar. But in general, people with diabetes are more likely to experience severe. It is irrespective of which type of diabetes you have, type 1 or type 2. But the good news is, if diabetes is well managed, then the risk of getting severely sick from COVID-19 is about the same as the general population. So a good controlled diabetic is perhaps the way to go. Next slide. Next slide. Yeah. So what happens when people with diabetes fall sick? Now, the illness and infection produces a form of stress, which basically triggers counter-regulatory hormones, which essentially are anti-insulin. So your patients get hyperglycemia. The acute illness causes a hypermetabolic state, and that releases cytokines as well. And I'm sure most doctors have heard about the cytokine storm that you get as a consequence of COVID-19 infection. So it happens with almost most infections. Obviously, this is more serious with perhaps COVID-19 infection. And this hypermetabolic state, when you are unwell, febrile, septic, okay, induces obviously the insulin resistance, okay, because of partly the counter-regulatory hormones. And all this drives to you getting a slightly higher risk of basically life-threatening complications in terms of either diabetic ketoacidosis or hyperglycemic state. Next slide. So this is a study from the Hubei province, it's a COVID-19 study from China, okay, where they looked at 7,337 cases. And the long and short of the study essentially is that well-controlled blood glucose is associated with reduced risk of all-cause mortality and detrimental complications that happen in patients with COVID-19, in those who already have diabetes. So if you look at the box above it, you can understand that those who are well controlled versus those who are poorly controlled, the all-cause mortality, the ARDS or the acute lung injury, the AKI, acute kidney injury, or the acute heart injury, all are statistically significantly affected in terms of poorly controlled diabetes. So having diabetes, well, you can't wish it away. Indira mentioned to you, it may take you good few months if you lose 15 kilograms in weight to wish it away. So it's a struggle to lose weight in COVID-19 times while you're at home and eating perhaps three meals a day. So you can't wish it away. Might as well have good control of your blood sugars. Next slide. So during intercurrent illness, there's generally an increased insulin requirement because of the counter-regulatory hormones, as I mentioned, particularly cortisol as well. The stress drives it. We also are aware of the fact, again, Somnath mentioned it, that there's basically an immunostimulatory effect of T cells, okay, with insulin receptor, okay, and that basically strengthens the host defense against infections. And the insulin dose may need to be up titrated, okay, because of the fact that you are now in an insulin resistant environment, which is acute, and it may be even necessary for you to take extra doses of fast acting insulin to bring the blood sugars down. Those patients who are on insulin, definitely all patients with type 1 diabetes, but even some patients with type 2 who are almost after many, many years of diabetes have very little insulin secretion from their pancreas. Remember, you should not perhaps stop insulin. Next slide. And what about the concomitant medication? Next, oral therapy when intensify injectable agents. Next. It's an animated slide, so you just need to run through it slowly. So with respect to SGLT2 inhibition, you perhaps can continue treatment. However, remember that DKA is more likely with an SGLT2 inhibitor, And as a consequence, you need to be aware of it, okay? Having said that, the comorbidities are worsened in patients with COVID-19. And dapagliflozin is actually conducting a trial called DARE, okay, to see if mild to moderate COVID-19 infections patients benefit with dapagliflozin or not. So we are still not sure of it, but the golden rule is when you're not well, stick to insulin. Next. With respect to metformin, perhaps you're okay with continuing metformin. Next. With respect to DPP-4 inhibition, if your patient is on an SGLT2 inhibitor with a GLP-1 receptor agonist, remember that to discontinue the DPP-4 inhibitor. Next. With regards to sulfonylurea, next, okay, you may have to reduce or stop the sulfonylurea if you put the patient on insulin, as well as when you're not well and you're perhaps not eating well, you may need to basically change the dose of sulfonylureas per se. Next slide. And with respect to TZDs, perhaps it doesn't matter that much. Remember, if you're on insulin as well, then there's an increased risk of heart failure. Heart failure is the buzzword these days in diabetes. So perhaps reducing the dose or perhaps even stopping the dose of TZDs might be a reasonable thing to do. Next. Next slide. So an ideal insulin, if we choose to use, must address all the challenges which are posed by these difficult times. We need the less consultation time. We need the flexibility and the convenience, okay, so that the patient adheres to this. Is it possible to demonstrate virtually how to take the insulin injection and manage it? Be able to explain them very simplistically speaking in terms of a simple regimen. Self-administration should be possible because trying to come in close contact with other human beings, your risk of developing COVID-19 infections would be higher. And remember, the most important thing, I think, in practical terms, is that as if you need to produce, check your blood sugars less frequently, then you perhaps can we unmute everybody? Or when you mute everybody? Okay. If you need to monitor for less frequently, that would be really a good thing, because the more frequent an injection that you give per day, that many times you need to even perhaps check your blood sugar. So the finger stick also goes up. So an insulin where you can start with it and stay with it is important. Something which can control both fasting and postprandial blood sugars is important. And obviously, the risk or the fear of hypoglycemia should not be there. Next slide. So in the Indian context, next slide. In the Indian context, okay, during these challenging times, remember that Indians are basically high carbohydrate eaters, okay? And they have high postprandial blood glucose as a consequence of the kind of foods we really eat. They also are on multiple oral agents as well, because obviously the fear of giving themselves an injection. So you need to titrate those doses when you start them on insulin. The limited consultation time perhaps forces you to use a drug which perhaps is fairly simple to use and it is convenient to use. And if you can start and stick to the same insulin as you up titrate the dose, then it definitely will reduce the errors. So the classic basal bolus regimen can be a struggle in this difficult COVID-19 times. Next slide. So this slide is just basically highlighting the fact that Indians consume more carbohydrate as part of their meals. So roughly up to 70 or 75% of the energy that we consume, the calories we consume, comes from carbohydrate, compared to perhaps just under 50% in the Caucasians. And as a consequence of this, we seem to have a fairly high postprandial glucose in our populations. Next slide. So if you want to address postprandial sugars, there should be some amount of prandial component. And this prandial component comes in the pre-mixed insulin, okay, and or in the co-formulation insulin. by giving this using this premixed or co-formulation insulin, you actually address the glycemic triad in diabetes. You basically address the PPG. You also address the fasting glucose, because there's also either an ultra long acting or an intermediately acting insulin in this mixture. And as a consequence, it addresses hemoglobin A1C. Next. However, if you just use basal insulin, you would struggle to lower postprandial sugars in quite a few of our patients. I'm not saying that will not happen in anybody. It may happen because you may use some of the oral agents to help you. But in India, perhaps in quite a few patients, you would struggle to lower their postprandial sugars. Next slide. So, co-formulation of premixed insulins has the ability for you to give total control in terms of the glycemic triad: fasting, postprandial, and hemoglobin A1C. Next slide. So I think Dr. Dasrathi Sarkar mentioned to you very nicely, when insulin was first discovered in 1921, and lo and behold, it was magic. Children, even senior patients of sort of elderly age or middle ages also, then given insulin, survived. Otherwise, most patients would die as a consequence of the glycemic complications per se. So, but after having done that and managed to basically result in the survival of these patients, we became aware that the chronic complications of diabetes occurs in these patients if they are not well controlled. So the industry took it upon itself to perhaps improve on the insulins. So while necessity is the mother of invention, it's very important from the point of view of the industry partners that they remain discontented to go and develop newer and newer insulins, which perhaps we as mankind do need to address this problem. So it reminds me of a very famous saying from David Rockefeller: if necessity is the mother of invention, the discontent is the father of progress. So if you're not happy, you will try and perhaps basically reinvent yourself, go back to the drawing board and produce something better for the society at large. Next slide. And that's what perhaps is there available in IDEG-ASP. It's a core formulation, okay? It's not a mixture, so it's a core formulation. So both the rapid acting component, basically aspart, coexists with the degludec dihexamers in solution. So it is not a mixture, it's a solution. So you don't need to shake the insulin before injecting. It's a solution, and whatever dose you give, 30% of it will be insulin aspart, and 70% will be slow-acting degludec, okay, which results in slow dissociation in the subcutaneous tissue. Next slide. So let's look at some studies, okay. Options for insulin initiation, co-formulation versus basal. If you have IDEG-ASP in the one arm and insulin glargine in the other arm. So in this study, about 296 patients, okay, 296 patients, this is an open label study, and you were given either IDEG-ASP, which was administered with the largest meal of the day, and or the other group was given insulin glargine, which was administered according to the label, which was either before breakfast or bedtime. Next slide. And at the end of 26 weeks, what this study really showed, next, there was superior reduction in hemoglobin A1C with IDEG-ASP compared to insulin glargine. As doctors, I'm sure it doesn't surprise us, because basically it has a rapid acting component to it, the IDEG-ASP, and obviously that perhaps provided the extra lowering of hemoglobin A1C. You also had a superior postprandial glucose control at the evening meal, okay, with the IDEG-ASP as well. Next. The fasting plasma glucose was similar, both with the insulin with the IDEG-ASP as well as insulin glargine. Next. However, the risk of confirmed hypoglycemia was far less. So there was a 27% reduction, okay, in hypoglycemia with IDEG-ASP compared with insulin glargine. Okay, showing you that you get a better A1C control, better PP sugar control, as well as a lower risk of hypoglycemia with the use of IDEG-ASP in our population. Next slide. What about, as I mentioned to you earlier, that you can initiate with this core formulation? What about stepping up? Okay, what about stepping up? And this is a study which I'd like to share with you, which essentially looks at the data in terms of co-formulation use, stepping up from once daily to twice daily, and versus basal bolus therapy. So on the one arm, you had IDEG-ASP, okay, which was given once daily, perhaps with oral agents, and then it was stepped up to twice daily, and insulin glargine in the other arm with insulin aspart, okay, as prandial insulin. So what you actually had was, when you compare the two arms, there was a randomization of 1:1. Next slide. What it showed was that twice daily co-formulation managed to give you the same kind of hemoglobin A1C reduction just as a basal bolus therapy you would use. But remember the practical issues. Previous slide, please. Remember the previous, the practical issues of basal bolus therapy basically involves up to 3 or 4 injections of insulin daily, and 2 different varieties where perhaps your risk of errors would be high. With respect to a co-formulation, stepping up is only from 1 injection a day to twice daily. And the practical aspect of stepping up is most patients eat 2 major meals a day. So you can use them as 2 injections, either say if you're having a heavy breakfast and a heavy lunch, then you can still use the co-formulations at breakfast and at lunch, okay, and still get away with good control. Similarly, you can do that at lunch and at dinner. I mean, you don't have to do it before breakfast and before dinner only, because the co-formulation is such that perhaps the basal component, you can actually vary it for up to 8 hours, okay, a day. So you can perhaps take it at a later time, or even at an earlier time if you need to. So that is the beauty of using the co-formulation. If you look at the data in terms of A1C control, similar, fasting control, similar. However, the risk of hypoglycemia, you can see statistically much reduced, okay, with the use of IDEG-ASP. So there is a statistical reduction in basically hypoglycemia by more than 10% numerically, but in terms of nocturnal hypoglycemia, when you use IDEG-ASP twice daily, there's a markedly or a significant reduction of hypoglycemia of over 40%. So again, showing you very nicely that this co-formulation is fairly safe, okay, in terms of lowering blood sugars, achieving targets with respect to hemoglobin A1C, and reducing the risk of hypoglycemia. Next slide. So, as I mentioned to you earlier, the practical problems of using a basal bolus therapy, you have to take 4 injections a day. And remember, you have to monitor your blood sugars 3 to 4 times a day as a consequence. Compared to that, when you basically up titrate your IDEG-ASP twice daily, from 1 injection to twice daily, you actually have to do only 2 injections. So you can only monitor twice daily and still get away with it. So fewer pricks, okay, compared to 6 to 7 pricks in somebody who's taking basal bolus regimen, to only 2 pricks for the insulin, and perhaps 1 or 2 pricks for the blood sugar. So 3 to 4 pricks maximum. Next slide. Next.
Yeah, you have to hurry up.
I think that's my last slide. So the key points is diabetes mellitus has been associated with severity and death in patients with COVID-19 with poor glycemic control. Patient-tailored therapeutic strategies, multidisciplinary team approaches, and lower thresholds for hospitalization of patients with diabetes and COVID-19 may impact positively on their outcome. And I think that's what we all are doing in our societies at large. Insulin co-formulation, that is IDEG-ASP, is a feasible option to address high fasting and postprandial sugars levels through a single delivery device, enabling adherence, good glycemic control, and fewer errors and fewer pricks in these difficult times. Thank you for your patient hearing. Next slide.
Thank you. Thank you, Dr. Shah, for your beautiful deliberation. Now we're running very late. Only 1 or 2 questions are allowed. You can have 1 or 2 questions, not more than that.
Yeah. Any questions?
Is there
in the
any
chat
question?
box?
No, thanks. Let me invite the second speaker, Dr. Kumar. Okay, no question. Dr. Vishnu Kumar.
Okay, thank you.
Indicating in the prevention of CKD. You know, the diabetic kidney disease is a serious microvascular complication of the diabetes mellitus, and it is associated with cardiovascular risk factor of cardiovascular morbidity and mortality. And this incretin has beautiful effect over these, not only the atherosclerotic diseases of the heart and other arteries, but also the kidneys also. They have antioxidant, anti-inflammatory action. They increases the natriuresis. The sodium excretion is increased, and also there is less fibrosis. This is a very important nephroprotective drug. And Dr. Kumar, please highlight this.
Good evening, sir. Is my slide visible?
Yes, yes, visible.
Respected chairpersons, senior and my dear colleagues, welcome to the 5th conference of Howrah Town Diabetes Study Society. A very good evening in a difficult times, and hoping to see a bright morning tomorrow. Without wasting much time, I'll just go to my topic, which is incretins in prevention of diabetic kidney disease. Now, first to understand what is its basics, which is glucagon-like peptide 1, GLP-1. Basically, it is produced from the pro-glucagon gene, which is located in the L cell of small intestine and is secreted in response to food, nutrients. So once the nutrients enters your intestine, this gene is activated and GLP-1 is produced. And basically, GLP-1 works by binding to its receptor, and the main effect is by stimulating the glucose-dependent insulin release from the pancreatic islets. But the problem is its degradation. The degradation occurs because there is an enzyme called DPP4, dipeptidyl peptidase 4, which keeps on degrading, and the half-life of GLP-1 is very less, 2 to 4 minutes. So what we have come with is a synthetic GLP-1 receptor agonist, which we are using as a therapy, which have a longer half-life and which can be more resistant to the degradation by DPP4. Now the injectables right now, which is there in the market, is exenatide, which is BD dosing as well as weekly dosing, lixinatide, liraglutide and dulaglutide, which is available in our country, semaglutide, and all these are approved in Europe and USA. And one of the drugs is also available as an oral formulation, which is semaglutide. Albiglutide has never launched in UK and was withdrawn in 2018. So this is what we have right now available in our market. But if you are trying to use this in CKD scenario, till what level can you go? So if you talk about lixinatide, liraglutide and dulaglutide, your cutoff in liraglutide and dulaglutide is till CKD stage 4. That GFR less than 15, the studies are not recommending it. And the others are between, like lixinatide is still GFR of 30 and exenatide is still GFR of 50. So the problem is we are in a state of deficiency of studies, which gives us a free hand to use in patients with CKD stage 5. But definitely before that, it can be used and has a lot of benefits. We will be discussing in the subsequent slides. Now, what happens in a diabetic kidney disease is there is hyperglycemia, which is causing systemic hypertension and glomerular hyperfiltration. The glomerular hyperfiltration by various mechanisms is leading to glomerular fibrosis. Then there is obesity. In addition to that, there is oxidative stress and inflammation. And incretin is said to cover all these factors like it can reduce blood glucose, it can reduce blood pressure, it can work like Dr. Indra also discussed, it can reduce body weight, it can be used as an antioxidant and anti-inflammatory. But having said that, all these things which I'm saying, does that translate into studies? We'll be discussing, I'll have taken only 4 studies, which was there, which has been published in 2020. And this article, which is basically a Japanese article, which is recently published in June 2020, it discusses beautifully about incretins in prevention of diabetic kidney disease, what theory says and what practically is the reality. Now, it has compared these 5 trials: the leader trial, sustain 6, rewind, award 7, and elixir. Now, all the trial was with GLP-1 versus a placebo, and award 7 was GLP-1, that is dulaglutide, versus glargine. And the primary endpoints in all these studies was basically the MACE or the cardiovascular endpoints. Renal outcomes was a secondary outcome. And the secondary outcome which looked in leader trial, which was liraglutide versus placebo, was new onset macroalbuminuria, doubling of serum creatinine, end stage, and renal death. In sustain 6 trial, which had a lot of positive feedback for this drug in CKD population, worsening nephropathy, persistent macroalbuminuria, doubling of serum creatinine below GFR of 45. Then the rewind trial and the award 7 had maximum patient with high level of CKD, like less GFR levels. So what was the result of this study is, if you see award 7, GFR decline was not much, minus 0.1 or 1.5. But definitely, if you see the trials, which is leader and sustain 6, hazard ratio of new onset macroalbuminuria was reduced, but they didn't have much effect on the GFR values, but urine ACR values definitely reduced in all these studies. So does that really translate in the progression of CKD? That we don't know, because in this article, they have also discussed 60 studies which involved 60,000 type 2 diabetic population, and they saw that reducing urine ACR did not translate to the reduction in the GFR. So even if the urine ACR was reducing, the GFR value did not show significant reduction when we are comparing with respect to placebo. Now GLP-1, theoretically, it reduces inflammation. Now all this part which we derive is basically from the animal study, the mice and the rat study, where we see if you are using GLP-1, there's reduction in the inflammation, there's increased natriuresis, which is there both in human studies and also in animal studies. There's reduction in the tubular injury, reduction in the oxidative stress, podocyte loss, and mesangial dysfunction and endothelial dysfunction. I'll just, I have little bit family problem. Can I take just 10 seconds after I attend a call? Can I take 10 seconds, sir?
Yes, yes.
Hello?
Okay.
Okay.
Okay. Can you hear me?
Okay.
So these are the mechanisms which has been proposed with GLP-1, which is causing renoprotection. But when we see the studies which is there so far, which shows that the renoprotection is actually limited. What this study shows that the clinical evidence at present is insufficient to support the observation. For instance, there's no established method for assessing the reduction in the oxidative stress and inflammation, which all these animal models are telling us. Secondly, clinical setting, glucose lowering, weight loss, and natriuresis, blood pressure reduction may account for renoprotection, but GLP-1 receptor agonist attenuates albuminuria, and that does not relate to the clinical renal outcome. So we need further studies which can actually address this issue. Then this second study, which assessed GLP-1 in transplant recipient. This was a systemic review and a meta-analysis, and which was published recently in June 2020. And this meta-analysis included 1,512 references, and 16 studies were included in the final analysis, which included 300 individuals with mean age of 55. And the conclusion of this study was evidence concerning the efficacy of incretin in diabetic kidney transplant patients is definitely limited. But what helps us to use this is the safety profile. Based on the safety profile, you can go ahead, but the outcome of the renal protection, you need more studies to actually give you the green signal to use it as a protective agent. But safety profile definitely helps you to use it in kidney transplant recipient. Then this third article, which is Journal of Nephrology, which was published in April 2020 by Mossad, it also described that how nephroprotective effect of GLP-1 receptor agonist is working. Where do we stand? This study also compared head-to-head all 6 studies, which is Alexa, Leader, Sustain 6, Rewind, Award 7, and Excel trial. Excel trial had the maximum number of population, that is 14,752. If you looked at into the various characteristics, I'll just highlight the important points. The glucose levels in Sustain 6 was higher. The mean HbA1c was around 8.7. And if you see the GFR value, or the patients who have maximum number of CKD population, maximum CKD population was in Award 7 trial, where the mean GFR was around 38. Whereas the other trials, you see the mean GFR was around 70 to 80. But here the albuminuria percentage was high. And the reason because the baseline population which was taken in Award 7 trial was having diabetic duration of 18 years. So definitely enough time was there to assess the complication, and diabetic nephropathy being a complication, this trial best addressed the issue. But population in this trial was only 577. However, when we see the results of this trial, the GFR decline did not, this was against the glargine, and the result was that GFR value did not vary. In fact, the decline was better in the glargine arm rather than the dulaglutide arm. But urine ACR reduction definitely was better with dulaglutide, which was significant, 25% and 43%. So even if you see the other trials also, the urine ACR reduction was better, but GFR translation, whether the decline in GFR is better, that was not very significant in all these trials. So having said that, theoretically we can say that definitely sodium retention is the green boxes represent the benefits, the sodium retention, glomerular hyperfiltration. These are possible with GLP-1, but hyperglycemia, hypertension, dyslipidemia is helping. Directly, we don't have the evidence. Indirectly, yes, it is there. Renal hypoxia, inflammation, it's a question mark. We don't know, but we need further studies to evaluate these effects on CKD population. So the conclusion of this article was safe to use in patient with diabetic kidney disease. Yes, it is safe, but whether it is truly nephroprotective, it remains to be seen. GLP-1 receptor agonist lowers the albuminuria. However, it is uncertain whether this will translate into the improvement in the hard renal outcome, because all these trials which I've mentioned are for cardiac benefit trials, but they didn't have renal benefit as their primary objective. So what we need is basically studies which can have renal benefit as a primary objective. Now the last article, which is published in Diabetic Therapy 2020, published in March 2020, this talks about the effect of GLP receptor on renal outcome in type 2 diabetes. Theoretically, it says that natriuresis is the effect of GLP-1. How? Both in animal studies and in human studies. What it does is there is a enzyme which is called as NHE3, sodium hydrogen exchanger 3. Now, what it does is basically it blocks that. When GLP-1 blocks that, there is increased sodium into the urine which comes out. Now, this is the diagram of a tubular cell, and this is the tubular part, and the right side is the basolateral or the blood part. So you see these are the enzymes. So here is the sodium hydrogen exchanger. So what it does, it blocks that on the brush border of the renal tubule. Hence, it increases the natriuresis. If that causes benefit, possibly or possible not, we will discuss this later. And there is some effect on hemodynamics also by GLP-1. Now, this was a study by Zhao et al. Which showed that liraglutide infusion improved the sodium and water handling and increased the GFR in rats. However, in human study, lixisenatide and exenatide and liraglutide showed no effect on renal hemodynamics. I'll tell you why. Because once the natriuresis is there, there is something called tubular glomerular feedback mechanism. Now, when the tubular glomerular feedback mechanism occurs, it reduces the GFR. But GLP-1 itself is a vasodilator. So what it does is, when the vasodilatation is working, then vasodilatation actually nullifies the effect of tubular glomerular feedback. So the GFR remains the same. This study also in Kidney International 2014 showed that liraglutide administered to mice delayed the progression of diabetic kidney disease by reduction in the mesangial expansion. What happens in diabetic kidney disease? There is mesangial expansion. So liraglutide reduced it in the mice studies. And some studies also suggested that renoprotective effect of GLP-1 is mediated by the metabolites of GLP-1. Now, the GLP-1, once you administer it, it breaks out into the various metabolites. It's a 30 amino acid sequence. So once it breaks out in various metabolites, one of these metabolites is working. That may be a possibility which some studies are suggesting. So these metabolites is associated with the lowered expression of renal tubular injury and markers and less tubular interstitial damage, and decreases the accumulation of macrophages and T cell in the kidney. That may be the possible one mechanism protecting the kidney. May not be related to GLP-1 directly, but maybe through its metabolites. Now, I've just enlisted this article in a chronological order, which
Dr.
has been...
Kumar, will you please conclude?
Okay. So these are basically kidney endpoints. Kidney endpoints is taken as a secondary endpoints. And if you see, these GFR was actually a neutral study, but if you see the new onset macroalbuminuria, these were significant. So what does this various study tell you? That microalbuminuria is definitely reduced. So studies so far suggest that renal protective effect of GLP-1 is there. There is a reduction in the broad renal composite outcome consisting of occurrence of macroalbuminuria. Doubling of serum creatinine may be reduced more than 40%. And for a follow of 3.2 years. But the renal benefit of GLP-1 receptor agonist was almost entirely driven by the reduction in urine albumin excretion, reduction in the urine albumin excretion, but does not end in the renal hard points. Whether there's a decline in the GFR, whether a patient didn't go for end-stage renal disease, that was not evident. So a recent trial, which is going on, and we expect the report to come by 2024, which is the FLOW study. FLOW study is a placebo-controlled trial, and it is using semaglutide. And semaglutide will tell us it has a primary renal endpoint, which can actually address this question that whether renal benefit will be there using these drugs. Now, what is the problem with GLP-1 is basically its receptors are there in the vascular smooth muscle, but there's no way to check the receptors. Or it may be there is immunohistochemistry or imaging is not enough to detect its expression. That is why it is becoming difficult to assess what is the real mechanism of GLP-1 when it comes to the kidney. So where is the nephroprotective effect coming up? Possibly through the glycemic control, possibly through the weight control, and possibly through blood pressure control. So you need more studies to actually assess the renal and the cardiac effect. GLP-1 receptors are there in the proximal diuretic, proximal tubules, which can cause vasodilator and can cause increased diuresis and natriuresis. There are 3 ongoing studies. One is the effect of GLP-1 receptor agonist in liraglutide on DKD, lixisenatide on the renal system, and FLOW study. We are waiting for the result. Then only this question can be better answered, whether it is really renoprotective or not. As of now, we don't have the answer whether it is translating in the clinical profile. This is in brief the various dosage. I'm sure you all know about this. And this is the, in brief, the mechanism how GLP-1 is working. And thanks to this monster is giant lizard killer monster. Through saliva of this, we have actually discovered GLP-1. Thank you. Any questions?
Move on.
Thank you, Dr. Kumar.
I have one comment.
Please go ahead.
Actually, all the participants.
Thank you, Dr. Kumar, for your very elaborative discussion. Thanks, Dr. Kumar. Yes, your comment.
Sir, Dr. Kumar's mother is very sick, but in spite of his personal problem and tension about his mother's health, he has delivered his lecture. It's a unique feat. We should congratulate him and hope for his mother's quick recovery.
Dr. Kumar, stop sharing your slide, please.
Yeah.
Okay. There's no question. Let me close the session. The next session.
Thank you so much, moderators and speakers. With this, we move on to the next part of the scientific session, and we move on to statins and superstatins' role in diabetes and diabetic distress. With this, I would like to welcome the moderator for this particular scientific session, Dr. S.K. Somani, who is a founder member and member of Scientific Affairs of Howrah Diabetes Study Society. He's a very senior reputed neurologist of Howrah with 38 years of experience. I welcome you, sir, on behalf of HTS, and over to you.
Thank you. I think I am audible. The first talk of this session is statins and superstatins, their role in diabetes. Statins, as we all know, are fecal metabolites, semi-synthetic in nature. Lovastatin received FDA approval in 1987, followed by simvastatin, but they are associated with serious side effects such as rhabdomyolysis and all. So in our quest for new molecules, superstatins, which are fully synthetic statins such as atorvastatin, rosuvastatin, etc., they were discovered. And now we are also hearing about PCSK9 inhibitors and some other tongue twisters. We have our learned cardiology colleague, Dr. B.P. Pandey, who will enlighten us about their role in diabetes. Dr. Pandey, please.
Thank you. Thank you, sir. So since we are running behind the schedule, my job is to tell you something about statins and superstatins. As you know, this wonderful molecule was derived from a product of a fungus, and the same one which gave us the antibiotics. And in fact, this gentleman, Dr. Brown and Goldstein, got the Nobel Prize for discovering the LDL receptor, whereas molecule compactin was discovered by Akira Endo from Japan, and 2 years later, it was by Albert from the Merck company. So we have a nice history for this. In fact, when I started graduation, a statin was not available at that time. We just read in biochemistry. So we have come a long way. So it is very important that we should understand that LDL cholesterol has got a linear correlation with the major cardiovascular risk factors. Each millimole, that is, if you reduce by say 39 milligram of LDL, it will reduce the event rates by 21%. Doesn't matter what is your baseline LDL level. Of course, if your LDL level is very high, the benefits will be much more. But it doesn't mean that reduction of LDL will not reap benefits. It is so important to understand this linear relationship. And it has been shown that reduction of LDL cholesterol leads to reduction of events in majority of the trials. As you can see, from the primary prevention trial to the secondary prevention trial, the benefit is 1 millimole reduction will lead to at least 21% reduction in cardiac events, that is death, MI, and stroke. So this HMG coenzyme inhibitors we are using very frequently nowadays. And nowadays we have got a few other non-statin molecules, particularly ezetimibe, when the goal is not met. And another superstatin, which is in the market for last 1.5 years, is PCSK9 inhibitors. We have got elirokumab and evolocumab already in Indian markets. There are few others which are still not available, but will come probably in next 1 or 2 years time, where probably we'll give in one injection in 6 month time and forget about LDL. So the superstatins are really coming in a big way. These are the molecules. Nowadays we use synthetic molecules like atorvastatin, rosuvastatin, and pitavastatin, unlike semi-synthetic Simva and Prava, which we used to use at least 20-25 years back. So these are all the data which has been studied in diabetic, non-diabetics, like CARDS was in diabetic patients. Every trial has shown that the high intensity statin is the talk of the town. So we have nowadays, we'll come to the algorithm when to use moderate intensity and when to use high intensity, just to highlight this point that high dose intensity statin like atorvastatin 80 was compared with 10 milligram in various trials, as Scott LLA and TNT trial, and it was shown that all the cardiac events are low. Although the TNT trial could not show reduction in the total mortality, but cardiovascular mortality was highly reduced. So we have to decide with particular patient which modality we are going to use, whether high intensity or moderate intensity, depending on the risk factor profile of that particular patient. And nowadays we are classifying whether the patient is in extremely high risk group, very high risk, moderate, or low risk. So all the patients has to be stratified depending on which score we are using. Like the Western world, they use either a score or Americans use some other score. I think for Indian patients, it is the JBS3 is the widely used score, which is more nearer to our population. Because if you use the high intensity statins, it has also been shown that the total plaque volume is also reduced. Not only the thin fibroatheroma is taken care of, it stabilizes the plaque. Of course, it has got various pleiotropic effects. There is not much of renal side effects, which was reported initially with rosuvastatin. So there is nothing to choose between rosuvastatin and atorvastatin. Both are highly efficacious. In fact, rosuvastatin might be slightly more potent than the highest possible dose of atorvastatin. Now, these two trials, one is the Odyssey trial, which is alirocumab in acute coronary syndrome, and Fourier trial, which was used in stable heart disease patient, evolocumab. These are the two PCSK9 trial, which is given in a bi-weekly injection dose, sometimes 3 times in a month, depending if your target is not met. So these are the real superstatins, and this algorithm is very important for primary prevention, that you assess the risk of that particular patient. You classify if your patient is between 40 and 75, look for the markers, whether he's a diabetic. If he's a diabetic, he'll go for high intensity statin. That means you have to reduce by 50% LDL. If he has got familiar hypercholesterolemia, once again, high intensity statin. If he has got established cardiovascular disease in the form of coronary artery disease, cerebrovascular disease, peripheral arterial disease, high intensity statin has to be used. We are not quite sure what to do between age of 0 to 19 and 20 to 39. Probably in younger population, rather than finding out 10-year risk, you find out what is the lifetime risk of cardiac events, and accordingly you plan them. But the earliest we should be able to measure the lipid profile if there is certain set of factors as early as 2 years of age. Because you know, statins are recommended to be used only after the age of 8 to 9 years. Only exception is the probably homozygous hypercholesterolemia. So this algorithm is very important based on age factor, based on the risk assessment. Whatever you classify, resort to the high intensity or moderate intensity statin. But if you are dealing with the secondary prevention patients, like in cases of established cardiovascular disease, then the goal is also streamlined. In majority of the patient from 40 to 75 years, nowadays, if he is a very high risk, you have to bring down the LDL to 55. If there is a history of recurrent MI, probably to 40 milligram per DL. But in all other patients, like high risk patients, you can be lenient. You can try to keep it down below 70. For diabetic patients, more than 10 years duration, I think majority of the patients you like to have LDL below 70, if not below 55. So the algorithm is nowadays important to understand, and LDL management is just like mathematics. If your say baseline LDL is 190 and you know rosuvastatin or atorvastatin highest possible dose is not going to reduce by 50%, that means 50% 180 is will never be able to reach 70 milligram. So these are the patients who will probably up titrate with ezetimibe after 2 weeks, find out once again LDL goal is still not met, probably will go with the PCSK9 injections. And there are certain situations where very upfront, we like to start with atorvastatin, ezetimibe, PCSK9, where we find that patient landing up with recurrent MI, and we know that will not be able to meet the target with one drug. Probably start all the gun blazing, and later on you can de-escalate your therapy depending on the LDL goal achieved. So it is very important to understand the role of superstatin, PCSK9 in high-risk category patients. So I think I'll end my presentation here. Thank you very much for the patience hearing.
Thank you, sir.
Thank you very much. Nice presentation.
Now is open for any questions, short 2 or 3 questions only, because we are running 1 hour late.
Everyone is eager to listen to Dr. Jishnu.
Yes, but we won't stay. Don't worry. I'll ask some of our members to ask and vex you with questions. Anyway, since there are no questions, we'll go to the next session, and it is on diabetes distress. And the speaker is our learned colleague, Dr. Jishnu Bhattacharya. Dr. Jishnu Bhattacharya, please.
Sir, am I audible?
Yes, you are audible.
Okay. First of all, sir, very good afternoon, good evening, and respected all dignitaries. And I am very much enriched with the knowledge of diabetes. I am not so much appreciated. So I'm starting. My topic of discussion is today diabetes distress, diabetic distress or diabetes distress. And from my point of view, it is very much important. Next slide. It refers to the emotional state where people experience feelings such as stress, guilt, or denial that arise from living with diabetes and the burden of self-management that is characterized by the extreme apprehension, discomfort, or dejection due to perceived inability or coping with the challenges and demands of living with the diabetes. Next slide. It is usually common and it's having worse health outcomes. It's more common in the patient taking insulin and type 1 diabetes. It is common. In a study of, next slide, study of 50 studies, there it has found that in type 1 diabetes, there are 1 in 5 patients having diabetes distress, rather than in type 2 diabetes, 1 in 4 patients having the diabetes distress. Now, there are 4 domains interconnected of diabetic distress. The first one is the emotional burden of living with diabetes, the distress associated with the diabetes self-management regime, the stress associated with the social relationship, and the stress associated with the patient-provider relationship. Next slide. The diabetes distress is associated with elevated HbA1c level, increased blood pressure, and increased LDL-C level. Actually, the slides are not. Next one.
Is this a slide or you want the next slide to this?
I will say na. Okay, sir. I'm bole debo sir. ঠিক আছে. Okay. Next slide. Sorry. There are 4 interconnected domains, specifically the emotional burden of living with diabetes, the distress associated with the diabetes self-management regime, stress associated with the social relationship, and the stress associated with the patient-provider relationship. It is calculated that it's associated with the elevated HbA1c level, increased blood pressure, and increased LDL-C level. Next slide. And it is found that there is more 1.8-fold more mortality rate and 1.75-fold more cardiovascular disease rate and decreased quality of life. Then what coming the risk factors for developing diabetic distress? First one is being younger, female, decreased education, living alone, having a higher BMI, lower perceived self-efficacy, greater perceived impact of glycemic excursion, lower perceived provider support, poorer quality diet, and greater number of diabetic complications. Next slide. There comes the symptoms of moderate depression. It is major depressive disorder is mainly having core symptoms three: low mood, anhedonia, or easy fatigability, and associated with decreased appetite, diminished sleep, decreased libido, some concentration difficulty. But in diabetic distress, the symptoms are specifically emotional response, that is unmotivated, burnt out, overwhelmed, frustrated, defeated, angry, guilt, denial, fear, specifically of hypoglycemia or diabetes related complication, lonely feeling, actions, maybe poor self behavior, and lack of adherence to the diabetes regime. Next slide. Now, what is distress? Greater diabetes distress is associated with the suboptimal diabetes self-management, HbA1c level, and impaired general emotional well-being. Diabetes distress is sometimes mistaken for and is more commoner than depression. Next slide. The PAID scale, that is the problem areas in diabetes scale, is used to identify the diabetes distress and to guide the conversation. Is the best managed with the context of diabetes care. Although greater diabetes distress tends to be associated with higher HbA1c, but it is not right that optimal HbA1c level or right HbA1c level having so patient having decreased diabetes distress. It is not so much. Next slide. In practice point of view, as diabetes distress is relatively common and also impacts upon self-care, it is important that every consultation includes opportunity for the person to express how they are feeling about the life with diabetes. Collaboratively set an agenda for the consultation, talk about what each of your priorities are for today, and agree about how much time to dedicate to each topic. It is for the consultant and also for the patient. Next slide. Now it is a schematic diagram of diabetes distress showing that there are many factors: burden of living with chronic disease, fear of failing at keeping up with the diabetic care, fear, anger, despair about living with diabetes, feeling of life being controlled by the diabetes, feeling not being supported by the healthcare provider, social isolation, and difficult qualities of life. Next slide. It is the flowchart interplay between the diabetes and major depressive disorder and other psychiatric disorder. Specifically, it is the highlighting point is that major depressive disorder and diabetes are having reciprocal susceptibility. And we all know that any psychiatric disorder, when we are giving any antipsychotic or any antidepressants also, they may be in antipsychotics, specifically atypical antipsychotics, increase the chance of diabetes, and major depressive disorder also causing the suicidal tendency rate, and the diabetes related to diabetic distress also causing this thing. And diabetes itself is a major risk factor for any type of psychological or mental health issue. Next slide. Greater diabetes distress. How will you understand? Suboptimal self-management, elevated HbA1c level, more frequent severe hypoglycemia, and impaired quality of life. Next slide. Now a term comes, that is diabetes burnout. Diabetes burnout is a state of physical or emotional exhaustion caused by the continuous distress of diabetes. Typically, the individual feels that despite their best efforts, their blood glucose levels are unpredictable and disappointing. Next slide. Signs of diabetes burnout. First one is the disengagement from self-care tasks like skipping the doses, not monitoring blood glucose, unhealthy or uncontrolled eating, not attending the clinic, and some risk-taking behavior. Next slide. How to identify the diabetic distress? First one is the suboptimal HbA1c level or unstable blood glucose level. Maybe fasting or second one is not attending the clinic appointment, reduced engagement with diabetes self-care tasks, ineffective coping strategies is very important for dealing with the stress. Multiple negative life stressors and chronic stress in distinct from diabetes. Impaired relationship with health professional and also family member, partners or friends, appearing passive or aggressive during consultations. Next slide. There are a diabetes distress assessment tool. Some points are there. It is not, I'm going through the detail. First one is the diabetes distress screener. Two items are there. Second one is a diabetes distress scale DDS, then 17 items self-reported questionnaire. Third one is the PAID scale, that is problem areas in the diabetes scale, that is 20 items reported questionnaire. The fourth one is the HTDSS, that is summary of diabetes self-care activities. Fifth one is the MDQ, that is multidimensional diabetes questionnaire. Now coming the next slide, diabetes distress screening scale. There are two items. First one is the feeling overwhelmed with demands of living with diabetes and having every point 6 points, every important point. The second one is the feeling that I am following my diabetes routine. Second, next slide. Now comes the major depression. I have actually said about the depression. It is important because diabetes distress and depression are sometimes collaboratively present and sometimes mistaken. Depression may be diagnosed as diabetes distress, or diabetic distress may be diagnosed as depression. So a brief questionnaire such as the PHQ-9 called Patient Health Questionnaire 9 can be used for assessing the severity of the depressive symptoms, and clinical interview is very much needed to confirm the major depression. Next slide. Major depression practical drawing. Assess the people with diabetes for depressive symptoms using a brief validated questionnaire. Remember that major depression needs to be confirmed by a clinical interview and some specific scale, HAM-D scale we use, and also in routine day-to-day practice we ask about the detailed history and is there the diabetes related problem or the life related problem. Then depression and diabetic distress can be differentiated. Next slide. In people with diabetes, depression or depressive symptoms, suboptimal self-management, reduced physical activity, less healthy eating, not taking medication, elevated HbA1c level, hypoglycemia and hyperglycemia also, increased prevalence, earlier onset or complications, and may difficult any disability. Increased risk of diabetes distress, elevated anxiety symptom, impaired quality of life and social role or functioning, increased burden or cost to the individual and healthcare system, and greater risk of premature mortality also. Right. Now the symptoms of depression and diabetes. Diabetes distress and depression having some common symptoms like fatigue, sleep disturbance, appetite changes, and irritability. But there are some specific symptoms in depression, that is concentration difficulty, having anhedonia, that is previously pleasurable activities are not so much pleasurable now. These are distinct points for the for the depression, major depressive disorder, and diabetic distress having not so much points in these things. Next slide. Depression or diabetes distress. That I am said, depression is often confused with diabetes distress both in academically and also clinical practice. While depression can influence the patient's personal life, and diabetic distress only affecting how they feel about life with diabetes or living with the diabetes. Diabetes distress includes problems related to the relentlessness and frustrations of everybody diabetes healthcare and worries about future complications. Next slide. There is a study of depression or diabetes distress. This means that almost 13% population having two symptoms ones associated, diabetes distress and depression. Only 10% diabetes distress and another 12% only depressive symptoms. Next slide. Now treating depression, it is a point of psychiatrist and also general physician. The depression can be treated by the pharmacological point of view, psychological point of view, and also the combination associated with interpersonal therapy and if needed cognitive behavior therapy. Cognitive behavior therapy is very easy to say but very difficult to do, and we are mainly doing that with pharmacotherapy and with the psychological interventions. Next slide. Now the key messages, to some extent very detailed. The experience of living with diabetes is often associated with concerns specific to the illness and can cause conditions such as diabetes distress, psychological insulin resistance, the persistent fear of hypoglycemic episodes. A wide range of psychiatric disorders, including MDD, bipolar disorders, schizophrenia, and spectrum disorders, anxiety disorders, sleep problems, eating disorders, and stress-related like GAD, obsessive-compulsive disorders are more prevalent in patients with diabetes than to the general population. All individuals with diabetes should be regularly screened for the presence of diabetes distress. Next slide. Compared to those with diabetes only, individuals with diabetes and mental health concerns have decreased participation in diabetes self-care and decreased quality of life. Cognitive behavior therapy, patient-centered approach as for example, motivational interviewing, interpersonal therapy, stress management, coping skill training, family therapy, collaborative case management should be incorporated into the primary care, self-management skills, educational intervention that facilitate the adaptation of the diabetes and addressing the co-occurring mental health issues, reducing the diabetes-related distress. Individual taking psychiatric medication, specifically I am speaking that the antipsychotics and atypical antipsychotics or some other also medication benefit from regular screening of metabolic parameters to identify the glucose dysregulation. Not only diabetes, there may be development of dyslipidemia or other hypertension, other medical issues also. So must be there screening of every patient who are taking about any antipsychotic or any antidepressant like medication. Next slide. Now, key message for people with diabetes. Living with diabetes can be burdensome and anxiety provoking, with the constant demands taking a psychological toll. As a result, many people experience distress, decreased mood, and disabling levels of anxiety. Diabetes is often associated with a significant emotional burden, distress over the self-care regime, and stress in relationship, family, friends, partners, everything. It is important to recognize your emotions and talk to your friends, family and members and your diabetes healthcare team, and if not possible then to any local physician, local RMP doctor, anyone, as in the rural areas not able to available anytime with the consultant. Mood and anxiety disorders are particularly common in people with diabetes. Eating, sleeping and stress related disorders are also common. Mental health disorders can affect your ability to cope with and care your diabetes. In view of this, it is just as important to look after your mental health and its physical health. Mental health is very important. As we know, there's WHO and for the last 3 years is focusing on the mental health and specifically on the depression, suicide and everything. And the people diagnosed with a serious mental illness such as the major depressive disorder, bipolar disorder, schizophrenia have a higher risk of developing diabetes than the general population. So next slide. I have completed here. Thank you. And last of all, I must say one thing, sir, to every dignitaries, all the speakers, respected sir, I am academically very junior for everyone, so I am very much enriched. Actually, in rural side, in suburban areas, I am getting the patients of associated comorbidities, so diabetes. So I have to treat them. I can't say to go to any other doctor. They will say, doctor, aro taka lagbe, ami parbo na, ekta jagate dekhate hobe. So it is very much helpful for me, sir. And if possible, any further program, please include me, sir. I just only want to be the learner. Thank you.
Thank you, Dr. Bhattacharya, for a very crisp and timely presentation.
Srimante, it's all yours.
1 to 2 questions may be allowed, I think.
Sir, actually we are running short of
Okay,
time,
okay,
so
okay. Then we will
kindly if we can
rush.
proceed.
Okay, then we will
Yes,
rush
sir.
up. Okay,
Yes,
thanks,
sir.
Dr.
Thank you so
Bhattacharya.
much.
Now, the next session will start.
Thank you, speakers, and thank you, moderators. Sir, we will move on to the second part of the scientific session, and that is role of ARNI in the management of diabetes and heart failure. With this, I would like to invite our patron, Professor Dr. Shibananda Datto, who is a senior consultant physician and cardiologist at Ashton Narayan Super Speciality Hospital and ex-HOD of IPGMER. Thank you so much, sir. Over to you.
Thank you. Can you hear me?
Yes, sir.
Yes, sir, we can. Yes, sir, we can.
Yes, sir.
Good evening. we are going to, without wasting any time, I would invite Prakash to start his deliberation on the army. All of you know that it has created a much interest in the recent times on the treatment of different facets of heart failure. And Dr. Hajra does not need any introduction to this gathering, and he is a very dynamic cardiologist, as you all know. I will ask him to start his deliberation as we are already late.
Thank you, Sivananda, Dr. Pandey, Dr. Shimani, and Midul, everybody over there, and wish you luck for tomorrow's program. ARNI in diabetic heart failure. So this is the molecule. So this is the molecule we'll be talking about today, that is ARNI, and is available in 3 forms, three doses, 50 milligram twice a day, 100 milligram twice a day, and 200 milligram twice a day. And it's a very costly molecule. And if you prescribe any costly molecule, what is the best place to start with? It is a hospitalized heart failure patient. When they're getting admitted in the hospital, they should go home, whether diabetic or non-diabetic. If it is REF, if it is a congestive cardiac failure, they should leave the hospital with ARNI in their prescriptions. Why? Because you are saving lives, though it's a costly, but over long term, it is cost effective. So if you prescribe ARNI, you are saving in the US 28,000 lives per year. And if you replace ARNI with S inhibitor, you are dropping down to 6,000. So all drugs are important, beta blocker, MRA, CFT, all are important, and these are all costly, but all should be prescribed in the first instance of heart failure if they can tolerate. Now there may be a debate whether 40%, 45%, 50%. I tell you, there is no clear-cut demarcation between REP, PEP, MREP. So MREP was born in 2016, but in 1985, the 35% ejection fraction was there for the cutoff of congestive cardiac systolic dysfunction. Now we have 45% as a cutoff in Paragon HA. So it's not always 40% and above is PEP, below 40% is REP. So there is a lot of overlap. And there was a time in consensus trial, people used to measure their chest exhale volume. If it is more than 650 ml per meter square, you have heart failure. From there, we have echo, we have global longitudinal strain, we have different other modalities to diagnose, to estimate, but I tell you, it is all arbitrary. And in the spectrum, we have high risk factors to the death. And in all this spectrum, some drugs work, some drugs do not work. For example, if you have MRA, spironolactone for hypertension, resistant hypertension, perhaps it reduces death and heart failure. Perhaps it reduces myocardial fibrosis. So this heart failure is a spectrum, and ultimately when they come to us, they come as a very sick person. And the chance or probability of death is very high. This ABCD staging, you know, somebody he is at risk, but when he gets acute coronary syndrome or a COVID situations, if their myocardium is damaged, he moves into class C. So in the clinical practice, he gets MR, he gets LV dysfunctions. Very unlikely that he'll go back to stage A again. But in the NYHA class, NYHA 1, 2, 3, 4, it is a continuous spectrum. Somebody who is 1 today may go into straightway to 4, but always can come back after myocarditis to stage 2, stage 1, even with a good drug, especially 4 drugs. And Indian heart failure, a little different. We develop heart failure 10 years younger, and we have much more risk factors in the Western populations like impaired glucose tolerance, metabolic syndrome, early habits of hookah, child labor, and we have a hypertension 10 years younger, more male than the female, valvular heart disease, more severe atherosclerosis, more diffuse disease, more young ACS, more smaller coronary arteries, difficult to do effective revascularations. And stress, poverty, air pollution from early age of life, teen obese YY paradox, and still we use not the guideline directed medical therapy, that is RNA beta blocker MRA, because of the poor socioeconomic conditions. Many of these people, when they admitted in the government hospital, they get good medicines, but when they go back home, they do not continue. So maintenance is very important. Lack of vaccinations. So these diabetic heart failure patients, you may be giving good drug, but he may be dying due to a corona infection where a vaccine might work, or influenza vaccines. IV iron is not an option for poor people, high salt intake. So these are the reasons why we Indians die early. Our mortality is much higher than any Western populations. But there are many countries in the European world where the mortality is as bad as India, maybe worse than India. But forget those countries, whether we can improve upon this. So on the left-hand side, you have some drugs that is called ARNI, the class 1 agent, though it is a single large randomized clinical trial. But the p-value was so overwhelming, it is equivalent to almost 5 randomized large clinical trials. We have many trials on beta blocker, MRA, multiple trials RCT. Diuretics do not have any RCT, but I tell you the first few hours, that is the best drug. I do not know where to place SGLT2 upon DAPA-HF. It is only one trial. You have this CRT, you have his bundle, you have CCM is coming up. This is FDA approved, the carotid body stimulations, IV iron, metformin, ivabradine, you have LVAD, you have to avoid certain drugs like insulin in heart failure in 2020. You should not use sildenafil, erythropoietin. And if you do not use ARNI in heart failure, that is also class 3, that is, you are going to do harm. And there is a lot of trials which has been stopped prematurely. If any trial is stopped prematurely, you should jump out from the bed and try to read about the trials. Like Consensus in heart failure, Jupiter, FAME trial in a cardiology, SPRINT trial, hypertension trial, but 20% reduction in heart failure. So if you go in the depth of any antihypertensive trial or hypertensive trial over the last 70, 80 years, the heart failure is ignored. But if you look the devil in detail, it is already there. Paradigm trial, ARNI trial, stopped prematurely, Credence trial, DAPA-CKD, COMPASS trial, BPI trial. And you see why? Because almost a double benefit than age-old. So S inhibitor ARB had their test of time, proven molecule, but we should move forward with newer generation of newer thinking of blocking the dual RAS pathway. So we have fabulous 4 in reduced ejection fractions, ARNI, SGLT2, beta blocker and MRA. All 4 have class 1 evidence. All 4 are independent of others. Only one RCT for ARNI, as I mentioned. All 4 gives death benefit. 3 are hormonal. 1 is not hormonal, not neurohormonal. And increment in the ejection fractions by 2 only, that is beta blocker and ARNI, not S inhibitor. So S inhibitor is weakest of all. And how many lives you can save in 2020? If you prescribe ARNI as a first agent, and you have a 2-year mortality, if you use other agents like S inhibitor, ARB, etc., your mortality is reduced by 25%. Now you add beta blocker, it is reduced to 16%. If you add MRA, and ultimately if you prescribe dapagliflozins and perhaps empagliflozins too, you are reducing the 2-year mortality almost 10%. That means if you treat 4 patients with NNT of 3.9, you can save 1 life, and relative risk reduction is almost 73%. That means you are almost 27% away from immortality. So that's the reality, that's the hard fact. Now we also know there are 3 types of agents: calcitrops, mitotrops, myotrops. There are some other agents will be available like omecamtiv, there is a myotrops, and the mitotrops are beautiful things like SGLT2, which works on mitochondria. And if you combine these things, it is incremental. So if you cannot use one drug like MRA for hyperkalemia or beta blocker for AA, the other drug like ARNI takes care of. So beta blocker, we are also improving. We are improving on the RNA. We are improving on SGL2. And you know, this long-term metabolic memory, like diabetes, if you have diabetes, you have metabolic memory, but your memory can be amnesia if you treat early. So in this trial, like DCT, DDIC, you have 9% before 10 years, and after 10 years, if you keep 9 and 9, and 9 and 7. So hit hard, it hit early with 7% below 10 years, 7% A1C after 11 years. So this metabolic memory will be lost. So similarly, this neurohormonal memory can be wiped out if you prescribe RD, beta blocker, MRA, and if they can tolerate, if they can afford, it is available, if it is attractive, and if your potassium is within the good range, it gives long-term benefit. It's Benny paradigm heart failure trial. You have a lot of people who had diabetes or pre-diabetes. Only 1/4 of these patients did not have diabetes. And look at the NNT, it reduces death over 27 months, all-cause death, heart failure hospitalization on top of best of standard of care. When the consensus or MRA was tried, they played against very weak player, nothing. Beta blocker was there later on, but in consensus in a enalapril trial, there was digoxin diabetic hydrolyzed and nitrates as an opponent. So in spite of having good opponent like beta blocker, MRA, you have one that is because of a good RAS inhibitions. You get extra bonanza, intensification of home medications reduced, ED visits are reduced, first hospitalization reduced, rehospitalization, so it becomes less frequent flyer to the hospital. Even your ICU stay becomes less. It acts irrespective of ejection fractions. So I also include MRF, HepPep, and definitely HepRep. Irrespective of the age, irrespective of the pro-BNP, high or low BP, diabetes or non-diabetes. And you look at the MES. I mean, in MES says you have one molecule now, and that both are diabetic, anti-diabetic. DAPA, 0.74. You look around any MES in any trial in cardiology, nobody can beat DAPA for the time being, or a sustained 0.74. So they are the first and second. Rest MPAREG is 14%, CANVAS 14%, and forget about the declare. And credence 20%. So this NNT is very important to understand. The single digit NNT is available with MRA, beta blocker. But ACE inhibitor or ARB is a very high NNT, and you have 27 for your RNA. So this is a Lancet May 2020. If you prescribe all four, as I mentioned, you are almost adding 6 to 8 years of life in a 60 years male who is diabetic. So isn't it amazing that you are getting extra benefits, less death, and extra quality of life, and it is exponential, that as long as you continue to use, you start reaping benefits all over your years. ARNI and no ARNI in DAPA. So whether you can start, we can start with DAPA, we can finish with ARNI, or start with ARNI, finish with DAPA, it's up to you. But there are certain things we have learned that in heart failure and diabetes, it's interrelated. Heart failure drug like ARNI prevent diabetes. Anti-diabetic drug like dapagliflozin prevents diabetes by 32% in comparison to metformin. And this is the trial on in the last line, dapagliflozin and dapa-HF in non-diabetic, it prevents diabetes and improves quality of life, and it improves very early. Now, dapa-HF, MPAREG, two different kind of animals. MPAREG much more well-to-do patients. Dapa-HF much sicker patients. So you have one with MPAREG a kind of people, but dapa-HF incredibly very sick patients. And if you go further from paradigm to dapa, dapa is much sicker than paradigm, and Victoria, very God, another molecule will be coming. They treat with very sick people with high pro-BNP class 4 molecules. And ultimately it saves life and it improves quality of life. Now, if you combine this paradigm and paragon, again, data may be diluted, benefit may be diluted, but in one direction that reduces heart failure hospitalization and severe death. If you combine paradigm with DAPA, if you do the meta-analysis again, same benefit, same outcome that prevents death, prevent hospitalizations. So ladies and gentlemen, to finish with, in 2020, you must treat all patients with aplereron, ARNI, carvedilol, SGLT2 in diabetics. I mentioned start low, go slow, except MRA, reassess after 4 weeks. For the symptomatic class, objective assessment, drug side effects, counseling for adherence, go for exercise, treat comorbidity like AF, sleep apnea, reduce their diuretic gradually, measure their GFR every 10 months. For example, if a GFR is 90 divided by 10 every 9 months. If it is 60, divided by 10 every 6 months. If it is 30, to start with, divided by 10 every 3 months. Try to accommodate evaporating, try to give IV iron, and we should wait for some more device like intra-atrial shunt, cardiac modulation pacemakers, LVAD, mitral cleave, and there are so many things coming up, and life will be more beautiful. With that note, I'd like to thank for kind listening. Over to you.
Thank you, Prakash.
Thank you. You want to unmute yourself?
Dr. Hazra, Prakash.
Yes,
This
Sanjay
is
Shah.
Dr. Shah. Yeah,
Yes,
hi.
sir.
Thank you for that
Hi.
lovely talk. Very exhaustive. But I mean, I understand you are perhaps recommending using 4 drugs, but presumably you have to do it step by step and not give all of them together. For all you know, your patient is going to die from the side effects of the drugs that you give simultaneously. Is that what you're suggesting? Or do you think, no, they should all be started because mortality rates are high and you actually want to reduce the mortality dramatically?
Yes, you are absolutely right. In some cases, in majority of cases, all 4 drugs, if they can tolerate, and most of them will tolerate once they are hospitalized. So hit hard, hit early like concept. You can always de-escalate, and later on, people will die for not prescribing drug. People will not die due to side effects. Like a hypertension is not going to die. If he gets giddiness, he's not going to die. If he gets amputation, little toe amputation, he's not going to die. But if you prescribe a drug like SGLT2, ARNI, beta blocker, sudden cardiac death, VT, VF, the life will be saved.
Thank you.
Thank you very much.
Thank you very much. You can go ahead with the program. Thank you.
Okay, thank you.
Thank you so much, doctors. Thank you, moderator and speaker. We move on to the last part of the scientific session today, and that is coping with COVID-19 pandemic, doctor's perspective. And for this particular scientific session, I would like to invite the moderator for tonight, who is Dr. Ashok Mukherjee. He is one of our patrons, who is a senior consultant physician and the teacher who is attached to HTS and enriched HTS with time. Thank you, sir. We welcome you on behalf of HTS. All over to you.
Hi, everybody. Good evening, my respected seniors, my dear colleagues and my juniors. It's nice to see you again, though I cannot see myself. I guess you all can see me, and that's nice. So I shall be sharing my screen. Yeah.
Am I audible now?
Yes, sir.
Yes, sir, you are.
21:30. Now am I audible, no?
Yes, yes.
Rajkumar, start your presentation.
Yeah. So, coping with the COVID pandemic from a doctor's perspective. This is me. I'm working some red zone areas of Howrah, and just one sec. So regarding when I talk about the work I do, this is my CV. of which confidentiality is a big thing, key aspect. So I am a little hesitant to discuss. Hello.
You are not visible.
There's a problem in his work. Because of that, I'm not able to spotlight on Rajkumarji.
Yes.
So was I visible before?
No, you're
No,
not,
you're not
you are not visible.
but we can see your slide, but it is not moving forward.
Yeah. Can I go to the next slide of yours?
Oh, sure.
Yeah, please. Okay, so my work involves one of the most ancient threads of the world, providing service for some important needs of the human body.
Hello.
Hello. Hello.
Can
Yeah,
you
Rajkumar,
mute?
continue. Yeah.
Yes.
Can you mute everybody, Naren?
Yeah.
Except the speaker. Except the speaker.
Sure.
1 second. Yeah, Rajkumarji, go ahead.
Yes. So I often ask my clients to move to the BOED and then expose for some strategic view and touch from my side. And nowadays in this COVID era, I often find them very hot in the bed as well. They breathe fast, their hearts heave heavily. But I must tell one thing, that I believe in establishing and maintaining strictly physical relations with my clients. I don't keep any emotional attachment with them. Next slide, please. So this is some principles we should remember. Behind every successful man, there is a woman, and after that woman will be that man's wife. So you can see some pictures of John F. Kennedy Jr., Marilyn Monroe, and Jacqueline Kennedy. There is a reason for that, because our wives are our sources of strength. All other women are our sources of weakness. Next slide. Coming back to the topic, coping with the COVID pandemic, we can summarize them regarding our personal experience, our social experience, our personal health experience, professional experience, and we shall talk a little about the commerce, the financial experience as well. Next slide, please. So when we talk about our domestic personal experience, our home basically has become our world. My elder son, who used to study in a West Bengal board school and who was in the process of transition to a CBSE board, he last visited school in 2009 November. So he has not gone to school for around 8 months. Both kids are getting obese, putting on weight for not playing, not going to the school. Parents are 77 and 69-year-olds. They are mostly homebound. When the Amphan hit, there was no electricity, no landline, no aquaguard, no internet for a few days. And I lost a glass pane, came in, the floor was wet, I fractured a toe phalanx. And there was no lift. I had to go down and come up 5 floors with that broken toe leg. And my cousin brother and other relatives are also becoming COVID positive at a regular interval. I have to support them over the phone. Next slide, please. So what is our social experience nowadays? So it is an experience of social distancing, how it is happening. My neighbors often are hesitating to play their kids with our kids because we are doctors. We are the carriers of COVID. Surprisingly, if the neighbor is a doctor, he's not minding. Perhaps because doctors understand doctors best. With our mask on, I had to attend a cousin sister's marriage. It was a very uncommon scene that both the bride and the groom were putting their mask on. Also had to attend the Shraddh ceremony of a fellow doctor who is 1 year junior to me, who lost his mother. When Jamai Shoshti was there, the COVID lockdown was going on, so had to decline the invitation. Our president of our housing society, he has become invisible. So for every damn problem, we cannot visit him. Everything is being done by his followers. And I found when the lockdown was going on, the Amphan destroyed the social distancing and the lockdown all. Also, because my hospital does not admit COVID patients, once they are documented COVID, we become a little distressed because what to do with our own relatives, because my hospital does not admit them. Next slide, please. So this is the financial crisis which I am facing. My hospital income nosedived in May. My variable income was altogether rupees 2,500 for 1 month. It was the salary for a couple of video consultations done with patients. Surprisingly, chamber income has not affected that much, because I am one of the few physicians who are still seeing fever patients in my own chamber. I have postponed all major financial decisions, and regarding the stock market, because the income has gone down drastically, have been forced to drastically decrease the SIPs of all the mutual funds. And when I see my portfolio value every day I think like, let me exit the market right today. I have not done yet. Next slide, please. So these are the professional crises. I shall divide it into hospital experience, nursing home experience, chamber experience, house visit experience, video conferencing experience, and the telephone experience. I shall go one by one. Next slide, please. The lockdown started on 22nd of March 2020. The hospital admissions went very drastically down starting from April itself. In May, as I told earlier, there was almost no patient for me. I had an UTI patient just because he was having fever. The learned COVID committee of my hospital declined to give admission to that UTI patient even. And in June, after 8th June, a couple of departments like cardiology, oncology slowly started opening up. Admission was still very low. In July, the OPD had regained momentum, but most of the patients were actually fever patients. 20% of my medicine patients are actually confirmed COVID cases. In July, in the month of July, I saw near about 180 patients attending my OPD. More than 30-40 patients had come with a documented.
45 মিনিট ডিলে আছে আপনার 10:15 আমি ফোন করে নেব যদি তার আগে হ্যাঁ ঠিক আছে
So 20% patients are confirmed COVID positive patients, and in August still COVID patients, they are coming, they are recovering, but IPD workload is still very low, very low. Next slide, please. So I am very grateful to my Narayana hospital, because the hospital has provided me PPE, mask, and one thing that has worked wonder, I believe it is a transparent fiber barrier between me and the OPD patients. I hope that is helping immensely in containing the infection from the patient to the doctor. But nowadays I have to plan my indoor round very carefully. The key part is that I should never move from a red zone to the green zone. Red zone means where suspected or confirmed COVID patients are there, and green zone means where there is documented COVID negative patients. So that we don't carry the virus from a red zone to the green zone, we have to carefully chalk out our daily round so that we move from green zone to red zone only. And once the red zone work is done, we need to leave the hospital. Next slide, please. I am sparingly attached to very limited nursing homes. I am not sure whether all of them are providing PPE or not. Basically, I am relying on my own headgear and mask for my own safety. I have found that possibly not all nursing homes are have their willingness to start COVID PCR testing. There might be other reasons for that as well. And in some nursing homes, I have come across alternative modalities to screen COVID. If there is a radiologist and CT scan machine in the nursing home, people have adopted an HTDSS screening to admit or to refuse admission for COVID, suspected COVID patients. Next slide. I do not have a, we shall be talking about the chamber experience. I do not have a personal private chamber. Most of the polyclinics where I work themselves dropped shutter in May, but they did not tell the patients that we are shutting down. What they told that, Dr. Babu ekhon ar bosche na. I am very grateful that they told je Dr. Babu ar nei. Some chamber owners and managers, they became COVID positive and they needed admission. Their chambers and polyclinics had to be temporarily shut down. Sometimes I had to liaise their admission into our hospitals. And once some of my patients came to know that I also see COVID suspect patients, from the outside I could hear that they wanted to cancel the appointment and leave. That is also another experience I have come across. Next slide, please. So I am trying to cope in the chamber. I am insisting that everyone puts on a mask. If the mask is hanging or dangling, I am not seeing the patient. I have to sometimes tell them that, look, your doctor is your COVID carrier. If you don't put up the mask properly, you might get it from the doctor, and then it works. I don't allow them to talk when they are sitting close to me for a physical examination. I have not curtailed the physical examination. I am trying to make it. I have come across patients who have got panic attacks, psychosis, denial, who will be denying that I could be having COVID, and have tried to address these issues with try some counseling and maybe sometimes with anxiolytic drugs. Many labs are refusing fever workup nowadays, so sometimes I have to, in addition, call up the labs for a possible dengue or malaria workup. Next slide, please. So this is the coping strategy which one of our fellow doctors adopted. He is the medical superintendent of one of our hospital. He barricaded his residential chamber's door with his own car, so that no patient can come and knock at his door. Quite nice strategy, I guess. Next slide. So I have not stopped the occasional neighborhood house visits because I believe if I am visiting the market, I do not know who is affected, who is not. And if I visit a house, possibly I know who could be the potentially affected patient. Therefore, if it is really urgent case, I have continued my house visits. But people have become clever. They are requesting me, please visit only before you enter your hospital. So they know that I could be having the virus, getting the virus from my hospital. They have got clever. And when I entered the house, I really had some very different types of experiences. Some relatives were almost on the verge of drenching me. They completely, in order to sanitize almost every part of my body and my clothes, I got sanitizers. I use black pen. One relative also requested not to use black ink for his mother's prescription. Unfortunately, his mother did die. I do not know what color they are choosing for their Shraddh invitation. Next slide, please. So this is something we are doing often nowadays, this video conferencing with patients. These were my sole source of income in the month of May, 2,500 rupees. I don't have an AC in my rented flat, and usually I roam bare-bodied. So whenever the time for the video consultations came, it was a nightmare for me because I had to put on a shirt. So my usual preferred dress code was a shirt for my torso and a Bermuda for my lower limbs. But once I finished the video consultation, then it was a paraphernalia like taking the photos of the prescription, cropping them, orienting them, rotate them, and upload them. It used to cause real pain for me. I'm quite a technologically challenged person. And because after some time I found this video conferencing was hampering with my rest after a busy, so I stopped doing them and politely trying to refuse the innumerable invitations to attend innumerable webinars nowadays, but could not refuse Dr. Shah. Next slide, please. And what's happening regarding the telephone calls? Long before the COVID pandemic, I had actually stopped sharing my personal mobile number with my patients. All they get is my secretary's number. If they have to call, contact me, they have to contact me through the secretary. But there has been some benevolent doctor colleagues of mine who have silently passed on my number. So I found that COVID patients started calling me. Doctor, such and such doctor told you are the very good doctor for COVID. He did not see me. Can you please see me? I told I remain equally a private doctor as he is. So you can go to him and go to a government setup. And because some super specialists went into hibernation, some very old patients again have started calling me. But some other patients have been really nice. They called my secretary not for their personal health problems, but they really were so nice that they wanted to know how I was doing. I remain very grateful to them. Next slide, please. So how am I coping? I had an acute attack of encephalitis last year. My hospital saved me that time. So this time, another pandemic going on, and I am a frontline COVID warrior. I am trying to save myself, being fanatic about putting the mask on. But unfortunately, because of the non-breathing nature of the PPEs we are being supplied in our hospital, it is becoming very difficult to put these PPEs on for more than 1-2 hours. I myself sweat a little more, and once we have the PPE, we literally get drenched with sweat. So after a couple of hours, I am being forced to put them off, drop them. I'm trying to save myself by practicing frequent hand sanitizing in between the patients. I had started hydroxychloroquine initially, but once the negative reports came, so stopped taking them. And every day after I am finishing my hospital duty, I am taking a long head shower with soap, which is a must. But still, after all said and done, I am not sure where I should go. If I actually contract COVID, the chances are high because my hospital does not admit COVID patients. Next slide, please. So regarding the mental health needs, I am always feeling sad when I come across that doctors are actually dying, succumbing to this infection. So I think of that famous scene of the Sholay, Ab Tera Kya Hoga Kaliya. I have tried singing, playing keyboards, writing poems, writing eulogies about friends when there was no workload. Have tried flying kites after 40 years during the lockdown days. Surprisingly, I found that I had not forgotten that skill completely. Even one day, I took a short day trip to the bank of Ichamoti. The place is Taki. It is on the Bengal and Bangladesh border. And watching the fantastic web series House MD on Amazon Prime, that is giving me the strength to move on. And people go on with dreams, also continuing to dream what vacations I might do if I survive this COVID pandemic. This is my parting words. I quote a few lines from a famous poem by Shukanto Bhattacharya. The name of the poem is Sharpatra. চলে যাব তবু যতক্ষণ দেহে আছে প্রাণ প্রাণপণে সরাবো পৃথিবীর জঞ্জাল এ বিশ্বকে এ শিশুর বাসযোগ্য করে যাব আমি নবজাতকের কাছে এ আমার দৃঢ় অঙ্গীকার I once had tried to translate it. The translation has been trashed, but I will just read it for the sake of it. I shall live, but still so long there is last throb of heart. I shall cleanse the world from garbage and dirt to make it a cozy niche for this child on earth. I promise the babe who has just taken birth. Thanks everyone. for your kind listening.
A very emotional and crisp presentation.
Thank you, sir.
Thank you. Thank you, Rajkumar, for that light-hearted view into your life.
Ask Dr. Mukherjee to speak.
Shobda, unmute karo.
Now can
you
can hear me?
Yes,
we
sir.
can
Yes,
hear
sir.
you now, sir. We can hear you now. Thank you.
No, I just want to thank Dr. Manna for giving his personal experience regarding this pandemic era. Actually, this is a huge socio-psycho and economical burden all over the world. And he has shared his experience. We are all enlightened with his personal experience, which is very heart-touching. I think we should not, we are already running late, and we should give a big round of Dr. Rajkumar Manna, please.
Thank you.
ক্ল্যাপ করছে আমার জন্য ক্ল্যাপ করছে
Maybe.
And I think the session is closed.
Okay.
Yes, sir. Thank you, doctors. Thank you so much. Over to Dr. Sanjay Shah, sir, if you could carry forward with the closing of today's scientific session.
Yes, that's good.
What I'd like to do is perhaps let Falguni basically say a few words with respect to what transpired today, and thank everybody who made this a grand success. Over to Falguni.
Hello.
Hello.
Good evening, ladies and gentlemen. We have come to the end of this wonderful scientific sessions today. It is indeed a virtual scientific feast on this Independence Day. Firstly, my thanks goes to all the attendees who has taken out the time and has been on this platform for the last 4 hours. The moderators that I would like to thank for conducting the sessions smoothly. To begin with, Dr. Sukumar Barik, Dr. M.L. Bhansali, Professor Dr. Arun Majumdar, Professor Dr. Dashwati Sarkar, Dr. S.K. Somani, Professor Dr. Shibananda Datta, Dr. Ashok Mukherjee. The speakers for giving us an insight and up-to-date knowledge in diabetes and its related specialty. Thank you to Dr. Somik Goswami, Dr. Somnath Nashkar, Dr. Indira Maisnam, Dr. Subhash Mukherjee, Dr. Sanjay Shah, Dr. Bismay Kumar, Dr. B.P. Pandey, Dr. Jishu Bhattacharya, Dr. Prakash Hazra, and Dr. Rajkumar Manna. Thank you to the young and talented Shravana Roy Chaudhary for her soul-stirring live performance. Indeed, many will remember this one. We cannot forget the contribution of each and every founder member of the Howrah Diabetes Society for making this event in a reality. The administrators whose hard work has been so fruitful in organizing today's event, Mrs. Joyti Bhattacharya has been on the forefront with her excellent organizational skills, ably supported by Shimanti Chandra and Rakhi Chatterjee. We would like to thank all our industry partners for supporting and sponsoring our scientific activities. In particularly, we thank Sanofi India, Sun Pharmaceuticals, Novo Nordisk, USV Pharmaceuticals, and Cipla Pharmaceuticals for sponsoring today's scientific session. Lastly, we thank Mr. Naren Rao and his team for virtually connecting us digitally uninterruptedly. We close this conference for today, the day one, and we wish to see you all tomorrow, day two, at 5:30 p.m. for another exciting day of science. Now I herewith Namaste and Jai Hind.
Thank you to Falguni
Namaste
also.
and Jai
Thank
Hind.
you, thank you.
Thank you.
Bye-bye.
I think
Hope to see you tomorrow.
it has been a long day. I think we close today. Mr. Rao, thank you very much for an uninterrupted session. And thank you, everybody, including the founder members. We wish to see all of you again tomorrow at 5:30.
I'll end the session.
Thank you.
Yes,
After
please.
the very
Thank you.
interesting session,
Thank you, Mr. Narendra Phale.
Thank you, sir. Thank you very
Thank
much.
you so much, sir.
Thank you, Mr. Narendra.
Thank you.
Okay, Mr. Rao, thank you. Thank you. Bye bye
Talk
and
to
good night, everybody.
Bye, everybody.
bye.
Bye.
Bye bye.